Welcome to this video entitled Respiratory Disease 2016 to 2017. As a way of introduction, a pharmacist with a specialist interest in respiratory medicine can have a major impact on the outcome of a patient with a respiratory condition. In order to achieve this goal, the pharmacist must develop an expertise in the field. This can only be achieved through a combination of familiarizing oneself with the national guidelines for specific conditions and keeping up to date with recent developments. To have an effective impact on the respiratory patient, the pharmacist must integrate into the respiratory team. This cannot be achieved by remaining on the periphery of the team and concentrating on prescription review and pharmacy-only issues. To have the biggest impact, the pharmacist must develop and promote her role within the respiratory team. Attending a consultant ward round, for example, is an opportunity to develop an in-depth knowledge of the treatment of the respiratory patient. It is also an opportunity to gain an understanding of prescribing decisions that may seem to conflict with some of the national guidelines. These prescribing decisions can then be seen in context. Being present at the point of prescribing will give you the chance to have the greatest influence on the drug management of the patient, the get it right from the start approach. There are other members of the respiratory team and it is important to fully understand their roles within the management of the patient. If, for example, a respiratory nurse specialist works within your respiratory team, this would in the first instance appear as a threat to the pharmacist's role. For example, the pharmacist may feel that their inhaler counseling role is no longer required. This is far from the truth. There is enough work to be shared around and it is a poor risk management approach to de-skill one profession because it is seen as the role of another. Within a respiratory team there are certainly overlapping roles, but for the team to work effectively there also has to be a complementing of roles. The pharmacist has a role because they look at the patient's drug management globally. The consultant may concentrate on the respiratory drugs, the respiratory nurse specialist may concentrate on the inhaler therapy, and the pharmacist can look at all aspects of the patient's medicine journey. Introduction. The primary function of the lungs is gas exchange. In the gas exchange process, oxygen needed for aerobic respiration in the mitochondria is sent to the blood and carbon dioxide produced as a metabolic byproduct is removed from the blood. This process consists of external respiration that involves lungs, internal respiration and the link between the pulmonary and peripheral circulation, as shown in Figure 1. Pause the video and scrutinize Figure 1 before advancing to the next slide. Ventilation is the process whereby gases are continuously transported between the atmosphere and the alveoli. Normally, there is only minimal resistance to ventilation, but in some disease states this is not the case and more effort is required. Diffusion involves the movement of oxygen from the alveoli into the pulmonary capillaries and of carbon dioxide in the reverse direction. Four factors are important in achieving satisfactory diffusion: adequate ventilation, adequate perfusion of the alveoli, balanced ventilation-perfusion ratio, respiratory membrane integrity, consisting of the alveolar wall, the pulmonary capillary wall and the interstitial space. A broad classification of respiratory disorders includes the following types: disorders of neural origin, restrictive e.g. pneumothorax, pulmonary fibrosis, and pleural effusion, obstructive that is COPD, and disorders affecting diffusion, pneumoconiosis. We will now discuss respiratory failure. Respiratory failure is a syndrome of inadequate gas exchange due to dysfunction of one or more essential components of the respiratory system, namely, 1. Chest wall including pleura and diaphragm. 2. Airways. 3. Alveolar capillary units. 4. Pulmonary circulation. 5. Nerves. And 6. CNS or brain stem. Furthermore, respiratory failure may be acute, chronic, acute on chronic. There are four types of respiratory failure, namely, 1. Type 1 respiratory failure is characterized by a. Hypoxemia, PaO2 less than 60 at sea level, failure of oxygen exchange, b. increased shunt fraction, that is QS over QT, c. alveolar flooding, and d. hypoxemia refractory to supplemental oxygen. Causes of type 1 respiratory failure include pneumonia, cardiogenic pulmonary edema due to increased hydrostatic pressure, non-cardiogenic pulmonary edema due to increased permeability, acute lung injury, acute respiratory distress syndrome, pulmonary embolism, which also occurs in type 4 respiratory failure, atelectasis, which also occurs in type 3 respiratory failure, and pulmonary fibrosis. 2. Type 2 respiratory failure is characterized by a. hypercapnia, that is a pH CO2 above 45 caused by a failure to exchange or remove carbon dioxide. b. Decreased alveolar minute ventilation VA. And c. It is often accompanied by hypoxemia that corrects with supplemental oxygen. Causes of type 2 respiratory failure are central hypoventilation, asthma, chronic obstructive pulmonary disease (COPD), neuromuscular and chest wall disorders, myopathies, neuropathies, kyphoscoliosis, and myasthenia gravis. Hypoxemia and hypercapnia often occur together. Type 2 respiratory failure is also associated with obesity hypoventilation syndrome. 3. Type 3 respiratory failure or perioperative respiratory failure is characterized by a. increased atelectasis due to low functional residual capacity (FRC) in the setting of abnormal abdominal wall mechanics. b. It is often results in type 1 or type 2 respiratory failure. c. It can be ameliorated by anesthetic or operative technique, posture, incentive spirometry, post-operative analgesia, and attempts to lower intra-abdominal pressure. Causes of this type of respiratory failure include, inadequate post-operative analgesia, upper abdominal incision, obesity, ascites, pre-operative tobacco smoking and excessive airway secretions. 4. Type 4 respiratory failure is due to shock. A. Type 4 describes patients who are intubated and ventilated in the process of resuscitation for shock. b. The goal of ventilation is to stabilize gas exchange and to unload the respiratory muscles, lowering their oxygen consumption. Causes of type 4 respiratory failure are cardiogenic shock, septic shock and hypovolemic shock. We will now discuss monitoring of patients with respiratory failure. Let's begin with arterial blood gases, abbreviated as ABGs. Arterial blood gases are used to quantify the magnitude of gas exchange abnormality and identify the type and chronicity of respiratory failure. In order to obtain arterial blood gas values, a sample of arterial blood is collected. Any artery can be used for this purpose except the radial and brachial arteries. The acid-base status of arterial blood is dependent on the respiration, that is hypoventilation or hyperventilation, and is dictated by the pCO2 values, which reflect changes in carbonic acid. This is because carbon dioxide dissolves in tissue fluids or blood to form carbonic acid. CO2 plus water yields carbonic acid, which dissociates into hydrogen ions and bicarbonate ions. pCO2 values are inversely proportional to the pH, therefore, in acute respiratory acidosis caused by hypoventilation, there is a decrease in pH, an increase in pCO2 and the bicarbonate levels stay generally the same. An increase in pCO2 and hence CO2 drives the above equation to the right, increasing the amount of hydrogen ions, which causes the pH to fall, resulting in respiratory acidosis. In addition, in acute respiratory acidosis, the bicarbonate compensatory mechanism performed by the kidneys cannot be switched on so quickly. However, in chronic respiratory acidosis, the bicarbonate blood levels tend to be high due to the renal compensatory mechanism causing reabsorption of bicarbonate. On the other hand, respiratory alkalosis is characterized by an increase in pH, a decrease in PCO2 and normal bicarbonate. Decrease in PCO2 shifts the above equation to the left, increasing the amount of CO2. This normally happens in hyperventilated patients due to panic attacks, pulmonary embolism, acute severe asthma and salicylate poisoning. Metabolic acidosis and metabolic alkalosis are characterized by reduced or raised concentrations of bicarbonate, respectively. As a compensatory mechanism, extra carbon dioxide is removed in acidosis by increasing the respiratory rate and, similarly, carbon dioxide is conserved in alkalosis by decreasing the respiratory rate. Metabolic acidosis is common in diabetic ketoacidosis, renal tubular acidosis, acute circulatory failure and sepsis. Metabolic alkalosis is also common in excessive vomiting or hyperkalemia. Normal ABG values are shown in Table 1 below. Table 1 – Normal values for various arterial blood gases while breathing normal air. Pause the video and carefully scrutinize the table before advancing to the next slide. Next we will discuss pulse oximetry. The best way to measure oxygen saturation is by pulse oximetry. Pulse oximetry measures the percentage of oxygenated hemoglobin, oxyhemoglobin, relative to total hemoglobin. The pulse oximeter is attached to the fingernail or to the skin. It is very easily applied and is an inexpensive piece of equipment. Pulse oximetry results are less accurate when oxygenation falls below 90%, in low cardiac output and if there is nail polish or skin pigmentation. It can also be affected by ambient light levels. We will now move on to full blood count. 1. Anemia may cause cardiogenic pulmonary edema. 2. Polycythemia suggests chronic hypoxemia. 3. Leukocytosis, a left shift, or leukopenia suggestive of infection. 4. Thrombocytopenia may suggest sepsis as a cause. 5. Cardiac serologic markers. 6. Troponin, creatine kinase MB fraction, abbreviated as CKMB. 7. B-type natriuretic peptide, abbreviated as BNP. We will now discuss microbiology. Respiratory cultures are obtained from the following specimens: sputum or tracheal, aspirate or bronchio-alveolar lavage, abbreviated as BAL, blood, urine and body fluid, e.g. pleural cultures. Next we will discuss chest radiography. It is done to identify chest wall, pleural and lung parenchymal pathology, and distinguish disorders that cause primarily VQ mismatch, clear lungs versus shunt, intrapulmonary shunt with opacities present. Next we will discuss the electrocardiogram. It is used to identify arrhythmias, ischemia, and ventricular dysfunction. Echocardiography is used to identify right and/or left ventricular dysfunction. Next we will discuss pulmonary function tests and bedside spirometry. It is used to identify obstruction, restriction, gas diffusion abnormalities. It may be difficult to perform if critically ill. Bronchoscopy can be done. It can be used to obtain biopsies, brushings and BAL for histology, cytology and microbiology. Its results may not be available quickly enough to avert respiratory failure. Bronchoscopy may not be safe in the critically ill. Regarding its management, we use the ABC, that is airway, breathing, circulation, approach. We should ensure airway is adequate. Ensure adequate supplemental oxygen and assisted ventilation, if indicated. Support circulation as needed. Treat specific cause, infection, airway obstruction, and cardiac function. Regarding ventilation, mechanical ventilation can be non-invasive or invasive. Non-invasive ventilation is more suitable for patients who can protect their airways and are hemodynamically stable. Invasive ventilation consists of endotracheal tube or tracheostomy if upper airway is obstructed. Indications for mechanical ventilation include cardiac or respiratory arrest, tachypnea or bradypnoea with respiratory fatigue or impending arrest, acute respiratory acidosis, refractory hypoxemia, inability to protect the airway associated with depressed levels of consciousness, shock associated with excessive respiratory work, inability to clear secretions with impaired gas exchange or excessive respiratory work, newly diagnosed neuromuscular disease and short-term adjunct in management of acutely increased intracranial pressure, abbreviated as ICP. The choice between the non-invasive over invasive ventilation should be made in the following settings: COPD exacerbation, cardiogenic pulmonary edema, obesity, hypoventilation syndrome. Non-invasive ventilation may be tried in selected patients with asthma or non-cardiogenic hypoxemic respiratory failure. The goals of respiratory ventilation are improvement of respiratory rate and tidal volume, assistance of muscle and neural dysfunction, correct respiratory acidosis, providing goals of lung protective ventilation are met, match metabolic demand, rest respiratory muscles, correct hypoxemia and improve cardiac function. Patients who have had an episode of hypercapnic respiratory failure should be given a 24% or 28% Venturi mask and an oxygen alert card endorsed with the oxygen saturations required during previous exacerbations, as shown in Figure 2. The oxygen alert card should be carried with the patient and presented at the emergency department when admitted. BNF October 2016. We will now discuss asthma. As a way of introduction, the mean prevalence of asthma in the UK is between 4 to 6%. There are 5.4 million people with asthma in the UK, which means asthma affects 1 in every 11 people and 1 in 5 households. The condition is highly prevalent in primary school children, of whom 15% have asthma. Whilst asthma is more prevalent in boys than in girls, the difference reduces with age and is not evident within the adult population. Approximately 1,600 deaths occur each year in England as a result of asthma, the majority of these occurring in the elderly asthmatic population. Many asthma-related deaths are considered preventable. Whilst the death rate from asthma is low in comparison to that for COPD, asthma has a major impact on the lives of patients. In a survey of over 50,000 people with asthma, 27% felt that asthma totally controlled their life. 25% experienced symptoms on a daily basis. 49% of adults had taken time off work or were unable to work at all. 71% of children had taken time off school because of their condition. The total cost of asthma to the NHS, including the payment of sick and invalidity benefits, has been estimated at £1 billion per year. Deaths from asthma are largely considered as preventable due to the availability of effective medication. However, the overuse of beta-2 agonists has been identified as a factor contributing to increases in morbidity and mortality from asthma. Next we will discuss the pathophysiology of asthma. Within the lung, mast cells are characterized by the presence of high-affinity receptors, abbreviated as Fc-epsilon receptor for the Ig/E molecules. On exposure to allergens or trigger factors, antibodies are produced which link the Ig/E molecules, thus activating the mast cells. Mast cell activation results in mediator release which collectively produces narrowing of the airways, that is bronchoconstriction, mucosal edema and hypersecretion of mucus. These effects are termed the early asthmatic response (EAR) and reach a peak approximately 15 to 20 minutes post-exposure to the allergen, resolving approximately 1 hour later. Some of the mediators released during the early asthmatic response attract inflammatory cells to the area, which also produce mediators. Thus a prolonged inflammatory response is observed and is known as the late asthmatic response (LAR). The late asthmatic response begins approximately 2 to 4 hours post-allergen challenge and is maximal after 6 to 8 hours. As a result of inflammatory mediators, the following effects are seen in the airways: 1. Shedding of the epithelium, resulting in hyperresponsiveness. 2. Excess mucus secretion. And 3. Reflex neural bronchoconstriction. The chronic inflammatory component of asthma is recognized in all patients with asthma, even in the absence of allergens, and hence other factors may contribute to sustaining the inflammatory component. Such factors may include an imbalance between CAMP, which is a bronchodilator, and CGMP, which is a bronchoconstrictor, or the release of neuropeptides, which results in bronchoconstriction. Hence, abnormalities in neural control mechanisms may contribute to the pathological changes seen with asthma. However, they are not recognized as being the major factor in causing such changes in either allergic or non-allergic asthma. If the inflammation is not controlled with treatment, as well as causing acute attacks, it can lead to permanent narrowing and scarring of the air passages, so that eventually asthma drugs fail to relieve the symptoms. This process is known as airway remodeling. We will now discuss the classification of asthma. Asthma can be classified as either extrinsic, that is atopic, or intrinsic, that is non-atopic, asthma as shown in Table 2. Pause the video and carefully scrutinize the table. Following diagnosis of asthma, a patient's condition will be classified as mild, moderate or severe, depending on the following factors: 1. The pattern and severity of airflow obstruction. 2. The severity of a patient's symptoms. And 3. The treatment requirements of the patient. Regarding its trigger factors and allergens, in patients with intrinsic asthma, exposure to a variety of trigger factors will produce the symptoms of an asthma attack but will not influence the underlying pathophysiology. However, patients with extrinsic asthma, when exposed to trigger factors, will produce IgE antibodies, prompting mediator release and consequently increased inflammation of the airways. Regarding allergy, approximately 80 to 90% of all patients with asthma are sensitive to at least one common allergen. Inhaled allergens such as house dust mite, animal dander, pollens and fungi are amongst the most common causes. In addition, some people are allergic to chocolate, milk, fish, etc. We will now discuss occupational asthma. Some patients may develop occupational asthma as a result of exposure and sensitization to a wide range of agents, e.g. flour, wood dust, various solvents, etc. It is difficult to estimate accurately the number of occupational asthma sufferers. However, approximately 555 new cases were reported to the Health and Safety Executive in the UK in 2004. It is estimated that 9 to 15% of adult-onset asthma patients are diagnosed with occupational asthma. Next we will discuss infection. Pulmonary infection is a common cause of an exacerbation of asthma, particularly in young children and the middle-aged. Viral infections are of particular concern, and whilst the mechanism is unclear, they are thought to cause bronchial inflammation leading to mucosal edema and increased secretion, as well as bronchoconstriction. Children are most susceptible to the respiratory syncytial virus, abbreviated as RSV, and the para-influenza virus, whilst the rhinovirus and influenza virus are more problematic for adults. Streptococcus pneumonia and Haemophilus influenza infections may also be causative agents. And now we will look at exercise-induced asthma. Some patients develop exercise-induced asthma, abbreviated as EIA, the bronchoconstriction being maximal some 5 to 10 minutes following cessation of the exercise. This condition is more common in young individuals, and whilst the mechanism is unclear, it is thought to be due to loss of water from the airways resulting in cooling and drying and hence bronchoconstriction. Regarding medication, the use of non-selective beta blockers may produce an asthma attack, and 3 to 5% of the asthmatic population are sensitive to aspirin and other NSAIDs. Other drugs that may precipitate an asthma attack include ACE inhibitors, hydrocortisone, penicillin and quinine. Regarding non-specific stimuli, changes in temperature and humidity can lead to airway obstruction. Regarding psychogenic asthma, emotional stress may precipitate an asthma attack in susceptible individuals. We will now discuss the clinical features and diagnosis of asthma. Cough, dyspnea, chest tightness and wheezing are characteristic features of asthma and may be of value in diagnosing the condition. Pulmonary function tests, notably peak expiratory flow rate, abbreviated as PEFR, forced expiratory volume in 1 second, abbreviated as FEV1, and the FEV1 to FVC, that is forced vital capacity, ratio are all reduced, and the degree of reduction will indicate the severity of the obstruction. Next we will discuss monitoring in asthma. Monitoring asthma is as important as treating it. Patients must be educated about their symptoms, medication and the use of peak flow meters. Patients are advised to keep a diary of asthma symptoms, frequency of rescue medication use and morning and evening peak flow measurements. Asthma UK has reported that 67% of asthma patients do not have their symptoms under control. Questionnaires and pulmonary function tests are used to monitor and assess asthma progression in general practice. The following factors should be monitored in primary care: 1. The management of asthma symptoms. 2. Lung function assessed by spirometry or PEF. 3. The number of asthma attacks, use of oral corticosteroids, time off work or school. 4. Inhaler technique. 5. Adherence. 6. Bronchodilator reliance. And 7. The goals and use of a personalized asthma action plan, abbreviated as PAAP. Next we will discuss pulmonary function tests. They include 1. Forced expiratory volume, abbreviated as FEV1, which is forced expiratory volume in 1 second. It is the volume of air exhaled in the first second of forced exhalation. It is expressed in liters or percentages of predicted values based on patient's age, height, race and gender. It is not effort-dependent. It is highly reproducible. It is not the best tool in acute asthma. Spirometers not as readily available as peak flow meters. Next we will discuss forced vital capacity, abbreviated as FVC. It is the total volume of air exhaled after deep inhalation. It is expressed in liters or percentages of predicted values based on patient's age, height, race and gender. Next we will discuss the forced expiratory ratio, abbreviated as FEV1 over FVC. It is the proportion of lung capacity exhaled in 1 second of forced exhalation. Volume time and flow volume graphs are generated by spirometry meters. Volume time curves are used to assess the adequacy of the test, and flow volume graphs depend on the mechanical function of the lung and can help to establish the diagnosis accurately. Next we will discuss peak expiratory flow, abbreviated as PEF. Peak expiratory flow is the maximal flow that a person can generate during fast exhalation. It is a measure of airway resistance of a frictional force created as the air moves through airways. It is recorded as the best of 3 with a maximum break of 2 seconds between blows. If the difference between two highest values is more than 40 liters per minute, then a further measurement should be taken. It is a good tool to assess diurnal variability in terms of percentage. It is a good indicator of patient's compliance and asthma control. Variability in peak expiratory flow is best calculated as a percentage of the mean or the highest peak expiratory flow value. Peak expiratory flow readings taken at work or away from work are a good tool to diagnose occupational asthma. It is very easy to perform and is the most frequently performed. It is highly effort-dependent and not as reproducible as FEV1. It is useful and used frequently in acute asthma. The most recent update from British Thoracic Society pointed out that peak expiratory flow has not proven to improve asthma control in addition to symptom score. This tool might be more beneficial in patients with severe asthma and bronchoconstriction. Peak expiratory flow values tend to peak at around the age of 35 years for individuals with normal lung function, as shown in Figure 3. Pause the video and carefully scrutinize the figure before advancing to the next slide. Pause the video and carefully scrutinize the figure before advancing to the next slide. Next we will discuss management of asthma. Table 3 below shows the general guideline used in the UK for treating adult chronic asthma depending on severity. Step 1 represents mild asthma and Step 5 represents severe asthma. Pause the video and carefully scrutinize Table 3 summarizing treatment of chronic asthma in adults as per the BNF. Inhaled corticosteroid doses are based on beclomethasone dipropionate, abbreviated as BDP hydrofluoroalkane inhaler. As previously stated, 80 to 90% of patients with asthma are sensitized to at least one common allergen that triggers their condition. Clearly, avoiding contact with such an agent is an important means of non-pharmacological management of the condition. However, in instances when this is not practical, a patient's drug treatment may be adjusted to allow exposure to the specific allergen. This avoids imposing inappropriate restrictions on the patient's lifestyle. The pharmacological management of the condition is based principally on two groups of drugs. We will now discuss preventers. These agents prevent the occurrence of an asthma attack and exacerbations, e.g. glucocorticoids, leukotriene receptor antagonists and chromoglycates. Regarding relievers, these agents relieve the symptoms of asthma, e.g. short-acting beta-2 agonists, long-acting beta-2 agonists, methylcanthines and anticholinergic agents. According to new guidelines from the British Thoracic Society, published in March 2016, patients with suspected asthma should be given a trial of low-dose inhaled corticosteroid, abbreviated as ICS, with short-acting beta-2 agonist, abbreviated as SABA, and then assessed for the response. If the patient is diagnosed with asthma, they should stay on the same treatment or move up the ladder if using short-acting beta-2 agonists 3 times a week or more. Therefore, according to BTS, Step 1 should include low-dose ICS with short-acting beta-2 agonist and Step 2 should have long-acting beta-2 agonist abbreviated as LABA added. Then in Step 3, if there is no response to LABA, the ICS dose should be increased to medium level. Next we will discuss the preventers. Let's begin with glucocorticoids. The mechanism of action of this group of drugs is still unclear. At a molecular level, inhaled glucocorticoids are thought to interfere with gene transcription, inhibiting the transcription of the genes responsible for the mediator cytokines, which are involved in asthmatic inflammation. Glucocorticoids are also thought to inhibit many of the mediators involved in airway inflammation. With prolonged therapy, the number of mast cells in the airways is reduced, thus reducing the amounts of mediators released. Glucocorticoids are also thought to inhibit plasma exudation and mucus secretion in the airways. In summary, glucocorticoids have an anti-inflammatory effect on the bronchial mucosa and they reduce airways hyperresponsiveness and bronchial edema. Inhaled glucocorticoids are proven to be more effective when used twice a day, except for a recently introduced inhaler containing siclizumide, which is used once a day. It is, however, possible to have patients on a once-daily regimen of the same total daily dose in mild and well-controlled asthma. Fluticasone is twice as strong as beclomethasone dipropionate and budesonide and its side effect profile is reported to be better, however more evidence is required. It is important to think about the device and the type of glucocorticoid used when switching between two different glucocorticoid inhalers. The BTS advise that some beclomethasone dipropionate hydrofluoroalkane inhalers are more potent than others and therefore they should be prescribed by their brand name. Equally important, asthma control should be taken into the account when switching from one glucocorticoid to another. For example, if QVAR inhaler is to be started from beclomethasone dipropionate easyhaler in well-controlled asthma, the dose should be halved. However, if asthma is not controlled well, then the change to a QVAR inhaler should be done at the same daily dose as beclomethasone dipropionate easyhaler. Foster is a combination beclomethasone dipropionate and formoterol fumarate CFC-free pressurized metered dose inhaler. It has extra fine particles and is more potent than traditional beclomethasone dipropionate CFC-free inhalers. Step 2 of the British Guideline on the Management of Asthma suggests that inhaled glucocorticoids should be started if short-acting reliever beta-2 agonists are used 3 times a week or more, exacerbations occurred in the last 2 years, asthma symptoms are present 3 times a week or more, or the patient is being awakened at night by asthma symptoms once a week. Other new inhalers include Relvar-Ellipta containing fluticasone and Vilanterol, and Flutiform containing fluticasone and formoterol. Due to the side effect profiles of these drugs, the favored route of administration is via inhalation. Side effects with inhaled steroids, although not serious, include oral candidiasis and hoarseness with 5 to 10% of patients affected. This problem can be alleviated by washing the mouth with water after use, or, in severe cases, nystatin or amphotericin lozenges may be used. In the long term, the use of a spacer device will reduce the proportion of drug deposited in the oropharynx. Inhaled corticosteroids at a dose equivalent to 800 micrograms per day of beclomethasone dipropionate in a beclomethasone dipropionate hydrofluoroalkane inhaler, not beclomethasone dipropionate CFC inhaler, are very rarely associated with any systemic side effects. The long-term effect on bone density is still uncertain. However, one systematic review reported that even 1,000 micrograms of beclomethasone dipropionate daily did not cause any reduction in bone density. In patients who are not adequately controlled by the use of inhaled steroids, oral steroids may be added to the treatment regime. Some patients will only require short bursts of oral steroid therapy, typically 30 mg daily until stabilized, whilst others require long-term maintenance therapy with high-dose treatments. The use of long-term oral steroids is associated with side effects such as osteoporosis, edema, hypertension, hyperglycemia, cataracts and classical Cushingoid features. When reducing such treatment, the dose is usually tapered off to avoid any exacerbation of symptoms and adrenal insufficiency. Short bursts of oral steroids may be stopped abruptly without ill effect. Intravenous glucocorticoids are used in the treatment of acute asthmatic attacks. In the 2016 update to their asthma management guidelines, the British Thoracic Society recategorized the dose of inhaled corticosteroids to low, medium and high dose, e.g. beclomethasone dipropionate for adults. Low dose corresponds to 400 micrograms daily, medium dose corresponds to 800 micrograms daily, and high dose corresponds to 1600 micrograms daily. Beclomethasone dipropionate for children, low dose corresponds to 200 micrograms daily, medium dose corresponds to 400 micrograms daily, and high dose corresponds to 800 micrograms daily. We will now discuss the leukotriene receptor antagonists. Leukotrienes are important mediators in the pathophysiology of the inflammatory process in asthma. The leukotriene receptor antagonists, montelukast and zifurlukast, block the effects of these mediators and thus exert an anti-inflammatory effect. They also exert some bronchodilator activity and are reported as being effective over a wide spectrum of disease severity. Leukotrienes can be added at Step 3 of the British Guideline on the Management of Asthma, and they have been shown to improve asthma symptoms and lung function and to prevent exacerbations. Nevertheless, the first-choice agents at Step 3 are long-acting beta-2 agonists, which must be used in combination with inhaled glucocorticoid. BTS advises that patients often benefit more from add-on therapy than increasing the dose of inhaled glucocorticoids. Next we will discuss the chromoglycates. Whilst the mechanism of action is unclear, disodium chromoglycate, abbreviated as DSCG, whilst initially thought to be a mast cell stabilizer, has been shown to be a poor inhibitor of mediator release. It has been postulated that the drug may activate a naturally occurring cell mechanism which is thought to switch off the release of mediators from mast cells. The drug may have an effect on the specific mediators, neutrophils, eosinophils and monocytes, thus explaining the action of the drugs in blocking both the early and late asthmatic responses. Another suggestion is that disodium chromoglycate may inhibit neuronal reflexes within the lung, a mechanism which nedochromyl sodium is also thought to exhibit. Due to poor oral bioavailability, DSC-disodium chromoglycate is only effective via the inhalation route. It is only effective if taken prior to exposure to the causative agent or if taken on a regular basis. When initiating therapy, it must be remembered that the drug may take several weeks, that is usually 4, to exert its full effect. Disodium chromoglycate is usually taken 4 times daily, that is 120 mg capsule via a spinhaler, or via a pressurized inhaler, that is 5 mg per puff. Children appear to respond better to disodium chromoglycate than adults and, as the side effect profile of the drug is minimal, the drug is particularly suitable for children. Side effects that may be observed include coughing, transient bronchospasm and throat irritation. The drug also has a bitter taste which may cause nausea, vomiting, headache or dizziness in some patients. Nedochromyl sodium has a pharmacological action similar to that of disodium chromoglycate. It is administered up to 4 times daily via a pressurized aerosol inhaler. Although once popular, chromoglycates have fallen out of favor due to variable patient response. Next we will discuss about omalizumab. Omalizumab is a monoclonal antibody used and approved by NICE for the treatment of severe persistent allergic asthma in children over the age of 6. It is used as an adjunct therapy to the standard therapy in children with IgE-mediated asthma who need repeated treatment with oral corticosteroids, i.e. more than 4 courses in a year. The dose is based on the IgE levels and body weight, please see SPC, and it is given up to 600 mg every 2 weeks by subcutaneous injection. As a recombinant DNA-derived humanized monoclonal antibody that selectively binds to human IgE, it interferes with the binding of IgE and Fc epsilon ion basophils and mast cells, thereby reducing the amount of free IgE that is available to trigger the allergic cascade. We will now discuss the relievers. There are 3 groups of relievers used in the treatment of asthma: 1. Beta-2 agonists, that is sympathomimetics. 2. Xanthines. 3. Anticholinergics. We will now focus on beta-2 agonists. Bronchial tone is controlled by both the sympathetic nervous system (SNS) and parasympathetic nervous system (PSNS), the role of the SNS being to inhibit the bronchoconstriction induced by the PSNS. The respiratory tree is sparsely innervated by the SNS, but beta-2 agonists interact with the adrenergic receptors, increasing the concentration of the enzyme adenyl cyclase, which is responsible for converting ATP to CAMP. The increase in CAMP results in bronchial smooth muscle relaxation. Beta-2 agonists used in the management of asthma are selective but not specific for beta-2 receptors, and hence, via beta-1 stimulation, side effects of the drugs, such as tachycardia and tremor, can occur, particularly with oral preparations and high-dose inhaled preparations. Salbutamol and terbutaline are the most widely used short-acting beta-2 agonists and are available in a wide range of formulations: liquids, tablets, nebules and inhalers. They are also more specific for the beta-2 receptors than other group members. Other drugs in this group include phentoterol, bambuterol, isoprenaline and orsiprenaline. The preferred route of delivery of the short-acting beta-2 agonists is inhalation, due to the quick onset of action of the drug and the low incidence of side effects. The onset of action of these drugs is approximately 5 to 10 minutes, with a peak bronchodilatory effect observed in 1 to 2 hours. The total duration of action is between 4 to 6 hours. Two long-acting beta-2 agonists, abbreviated as LABAs, are available commercially, namely, salmeterol and formoterol. These drugs have duration of action of approximately 12 to 15 hours and hence are not intended for the relief of acute symptoms but rather for the prevention of symptoms, particularly nocturnal symptoms. Salmeterol has an onset of action of approximately 20 minutes, whilst that of formoterol is much shorter, 1 to 3 minutes. Both drugs are only available via the inhalation route and are recommended to be administered twice daily. Long-acting beta-2 agonists are indicated for the control of nocturnal symptoms and to prevent exercise-induced bronchospasm. As mentioned previously, LABAs should always be used in combination with inhaled glucocorticoids. Even with the potential side effects of LABA, the benefits outweigh the risks, and LABAs should be added to the therapy if a patient's asthma is not well controlled on inhaled glucocorticoids only. Combination inhalers such as Seretide and Symbicort have not been shown to be more efficient than individual inhalers, however they tend to increase patients' compliance. Also, Symbicort can now be used as a reliever in patients whose asthma is not well controlled on inhaled glucocorticoids only. When Symbicort is introduced to asthma management, the total regular daily dose of inhaled glucocorticoid should stay the same. Patients quite often use Symbicort regularly, dosed at 1 or 2 puffs twice daily, plus when required. The maximum daily dose is 8 puffs. Duo-Resp Spiromax budesonide with formoterol can also be used as a reliever. Patients using budesonide with formoterol as a reliever once a day or more should have their treatment reviewed regularly. Next we will discuss xanthines. Theophylline is used in an oral sustained-release form. The mechanism of action of the drug is unclear and a number of possible mechanisms have been postulated. 1. Competitive inhibition of the phosphodiesterase enzyme, which is responsible for the hydrolysis of CAMP bronchodilator. 2. Inhibition of adenosine, preventing mediator release and hence the related bronchoconstriction. 3. Influence on calcium flux. The related therapeutic benefits of the xanthines are therefore: 1. Smooth muscle relaxation. 2. Inhibition of mediator release. 3. Increase in mucociliary transport. 4. Suppression of edema. And 5. Anti-inflammatory activity. The drug has a narrow therapeutic index of 5 to 20 micrograms per milliliter and hence requires therapeutic drug monitoring. Higher levels are needed for its anti-inflammatory effect. A number of different brands of theophylline are available commercially, but due to different release characteristics it is advisable to stick to one brand, preferably one with a number of dose presentations. Sustained-release theophylline preparations are normally given on a twice-daily basis. The ethylene-diamine salt of theophylline, aminophylline, is available for intravenous use and is important in the treatment of acute severe asthma. There are oral aminophylline preparations available, but there is little advantage in using this agent orally when theophylline is itself readily absorbed from the intestine. The adverse effects associated with theophylline include tremor, tachycardia, nausea, heartburn, convulsions and sleeplessness. Drug interactions are particularly important with theophylline since the drug has a narrow therapeutic range. Theophylline is highly metabolized in the liver 90%, and any factor which leads to changed enzymatic activity in the liver can lead to major changes in theophylline serum concentrations through changed clearance of theophylline from the body. Smoking, for example, stimulates liver enzymes. A patient that stops smoking and is stabilized on theophylline can develop theophylline toxicity as the liver enzyme activity returns to normal. Another major worry is life-threatening toxicity due to administration of emergency intravenous aminophylline to patients already receiving oral theophylline. A summary of some important factors that influence theophylline kinetics are presented in Table 4 below. Table 4 shows factors that influence the pharmacokinetics of theophylline from Darcy and McElnay, The Pharmacy and Pharmacotherapy of Asthma, 1989, publisher Ellis Horwood Limited, Chichester. Pause the video and carefully scrutinize Table 4 showing the factors that influence the pharmacokinetics of theophylline before advancing to the next slide. Next we will discuss anticholinergics. Anticholinergic drugs competitively inhibit the action of acetylcholine at muscarinic receptors within the PSNS, resulting in bronchodilation. The drugs are administered via the inhalation route due to the unacceptable side effects associated with oral administration. Ipratropium is widely used in the therapy of asthma. It is usually employed in combination with a beta-2 agonist as the effects are additive. It is particularly of value in patients over the age of 40 when beta-2 responsiveness tends to decrease. Ipratropium is available for use by inhalation and by nebulization. It is usually given at a dose of 40 to 80 micrograms 4 times a day. It has a slower onset of action than beta-2 stimulants, with a maximum effect 30 to 60 minutes after use. The duration of action is, however, somewhat longer and bronchodilation can usually be maintained with thrice-daily dosing. The incidence of side effects to the inhaled anticholinergic is rare. There is no evidence for any change in mucociliary clearance, sputum volume or viscosity. It may produce a transient bitter aftertaste. Care should be taken to avoid getting the drug into the eyes, e.g. by escaping from the mask during nebulizer administration, since an atropine-like response will occur. Cases of acute, closed-angle glaucoma have been reported. Adding a short-acting anticholinergic at Step 2 of the British Guideline on the Management of Asthma does not generally benefit asthma patients, it is more beneficial in COPD patients. Next we will discuss inhaler devices. A diverse range of inhalation devices are available for optimal administration of drugs into the lungs. Space does not allow a discussion of the individual merits of these devices. Students should refer to the manufacturer's directions. Regarding inhaler technique, selection of an appropriate inhalation device is clearly important in terms of effectively treating the patient's condition. However, just as important is the ability of the patient to use the inhalation device correctly. The British Thoracic Society guidelines state that inhalers should only be prescribed after patients have received training in their use and have demonstrated satisfactory technique. Clinical pharmacists have an important role to play in instructing and assessing patients on their inhaler technique. The following checklist can be used when instructing patients in the correct use of a metered dose inhaler. 1. Shake the inhaler and remove the cap. 2. Hold the inhaler upright. 3. Breathe out fully through your mouth, emptying as much air from your lungs as possible. 4. Close lips tightly around the mouthpiece. 5. Press the canister as you start to take a long breath in through the mouth. 6. Close mouth and hold breath for 5 to 10 seconds before slowly breathing out. We will now discuss nebulizer therapy. There are growing concerns regarding the use of nebules and respules for the treatment of respiratory conditions, and hence, as a result, guidelines on the current best practice for nebulizer therapy have been published by the British Thoracic Society. In asthma, nebulized bronchodilators should only be used in chronic severe asthma for the relief of symptoms at steps 4 or 5 of the British Guidelines for Asthma Management. Nebulizer therapy should only be considered following a review of the diagnosis, if the airflow obstruction is reversible and providing the patient is receiving high-dose inhaled prophylactic therapy and is complying with the prescribed dose. The patient's inhaler technique should also be assessed to ensure it is satisfactory. Patients must also be prescribed a larger dose of bronchodilator using a handheld device, as 4 to 6 puffs of bronchodilator delivered via an MDI and a spacer device, every 6 hours, produces the same effect as nebulized therapy. Following these assessments, if a patient is considered as needing nebulized bronchodilator therapy, a trial of domiciliary treatment for a 2-week period should be initiated. During this time, PEFR should be monitored twice daily before nebulization, on rising and before going to bed. An additional PEFR measurement should be taken 30 minutes after treatment each morning. If the trial has shown clinically useful bronchodilation, 15% or more increase in PEFR following bronchodilation, without unacceptable side effects, long-term nebulized bronchodilator therapy may be prescribed. Typical doses for nebulized bronchodilator therapy are 2.5 mg salbutamol, 5 mg terbutaline or 250 to 500 micrograms ipratropium bromide. Nebulized bronchodilators should always be given via oxygen-driven nebulizers. Nebulized therapy is recommended in acute severe asthma and it is used very often in hospitals. There is no conclusive evidence which determines whether intravenous administration of beta-2 agonists is better than nebulized beta-2 agonists. However, the first choice would always be nebulized bronchodilator therapy, which should generally produce a response in 10 to 15 minutes. Otherwise, if there is no response, intravenous bronchodilators can also be started. It is important to remember that ipratropium bromide mixed with salbutamol in a nebulizer produces a better bronchodilation effect than either agent alone. In a mild to moderate exacerbation of asthma, the evidence shows that beta-2 agonists delivered via MDI plus spacer are as effective as using a nebulizer. With regards to nebulized steroids in chronic asthma, there is no evidence that using a nebulizer is better than an MDI plus spacer, however doses above 2 mg are only licensed to be given via nebulizer. As much higher doses are delivered via nebulizers than via inhalers in acute severe asthma and severe chronic asthma, it is important to monitor patients for side effects. With beta-2 agonists, the most common side effects include tremor, tachycardia and hyperkalemia. Generally, patients are given 2.5 mg of salbutamol 4 times daily and this dose is generally well tolerated. There is a school of thought that giving 5 mg rather than 2.5 mg of salbutamol 4 times a day won't improve bronchodilation but will cause more side effects. Nevertheless, British Thoracic Society guidelines on management of acute severe asthma recommend 5 mg of salbutamol or 10 mg of terbutaline via nebulizer. See the anticholinergics section above for side effects. Once patient is ready for discharge from the hospital, inhalers should be introduced at least 24 hours before discharge to ensure they do not deteriorate once administration via nebulizer ceases. Patients should have their inhaler technique assessed and recorded before discharge. Next we will discuss personalized asthma action plans. Many studies have shown that written personalized action plans, when used as part of the self-management education of patients, reduce the number of A&E attendances and hospitalizations and improve health outcomes for asthma patients. A consistent finding in many studies has been improvement in patient outcomes such as self-efficacy, knowledge and confidence. The British Thoracic Society recommends that self-management programs should include 1. Structured education, reinforced with written personalized asthma action plans. This can be downloaded from www.asthma.org.uk/control. 2. Specific advice about how to recognize loss of asthma control by monitoring symptoms or peak flows. 3. Action to take if asthma deteriorates, including seeking emergency help. 4. Commencing oral steroids. The patient may require a supply of steroid tablets for use in an emergency, and recommencing or temporarily increasing inhaled steroids, as appropriate to clinical severity. Hospital admission represents a good opportunity for self-management skills to be reviewed. Pharmacists are in a good position to do this. The following points can be addressed: acute asthma attack management, advice on upper respiratory tract infections and other known trigger factors, including trigger avoidance and smoke-free environment, should be provided, reiteration of the patient goals and further education should be provided. It is important to check the patient's adherence to medication, inhaler techniques and trigger factors before stepping up and increasing the number and/or doses of therapeutic agents. Patients are quite often put on a short-term trial with certain medications. Depending on the asthma symptoms and the type of therapeutic agent used, the duration of trial may vary. Quite often these patients are not reviewed regularly and are left on a trial course for longer than they should be. The pharmacist should engage in conversation with the patient and inquire about their medication history in order to gain better understanding of the patient's asthma management. Following this, if appropriate, the pharmacist should speak to the doctor to review the trial medication. Next we will discuss chronic obstructive pulmonary disease, abbreviated as COPD. As a way of introduction, the majority of respiratory patients encountered by the clinical pharmacist in secondary care will have COPD. COPD is characterized by airflow obstruction. The airflow obstruction is usually progressive, not fully reversible, and does not change markedly over several months. The disease is predominantly caused by smoking. The term COPD refers to a group of respiratory diseases characterized by airflow obstruction. It is an umbrella term that covers a number of conditions, the most common of which are chronic bronchitis and emphysema. Previously, the terms chronic bronchitis and emphysema were used in isolation. However, these terms tend not to be used on their own any longer as a single diagnosis because there is usually an overlap of the conditions. However, it is useful to have an understanding of each of the elements of COPD, as shown in Figure 4. Pause the video and carefully scrutinize Figure 4 illustrating the main elements of COPD before advancing to the next slide. There is generally airway obstruction with wheeze and breathlessness. Patients with chronic bronchitis often also have emphysema, and on occasions chronic bronchitis and asthma may coexist. The condition occurs much more frequently in men than in women, in town dwellers than in country dwellers, and in lower socioeconomic groups. The incidence in the UK is of the order of 10 to 15% of middle-aged men, with a mortality rate of 80 per 100,000. Emphysema is defined as a condition characterized by enlargement of air spaces distant to the terminal bronchiole with destruction of the alveolar walls. This results in deterioration in gaseous exchange and impaired ventilation. The diagnosis of this condition requires anatomical confirmation. Classification is based upon the area of the lung involved, with the two main types being 1. Centrilobular. In this case the damage occurs in the respiratory bronchioles and at the center of each lobule. 2. Pan-asana. This case affects most of the alveolar tissues of the acini. Clinically important emphysema is of two varieties, 1. Primary or idiopathic. 2. Emphysema associated with chronic bronchitis. There are other types, such as that associated with Kohlmeiner's pneumoconiosis. Primary emphysema accounts for only 10% of all cases of emphysema in the UK. In contrast, emphysema associated with chronic bronchitis represents about 60% of cases. Regarding morbidity, it is very high, involving frequent primary and secondary care. 1 in 8 emergency admissions are due to COPD. The mean length of hospital stay is 9.1 days. It is more common in winter months. Consultation rates are double those for angina. A GP practice will see 20 new patients annually. There is a greater incidence in more deprived areas. Regarding mortality, it is difficult to ascertain. Patients will die due to COPD, but death certificate may state other cause. 2007 to 2009 there were 25,000 deaths, 4.8% of all deaths. The 5-year survival rate is 70%. It is higher in males than females. Next we will discuss the etiology of COPD. There are a number of causes of COPD. Smoking is the main cause. However, not all smokers develop COPD, and approximately 5 to 10% of patients who develop COPD have never smoked. Therefore, there are other causes which can be classified as host factors and environmental factors, as below. Host factors include 1. Genetic factors such as alpha-1 antitrypsin deficiency. 2. Airway hyperresponsiveness. 3. Atopy, which is associated with allergens, e.g. house dust mite. 4. Gender. This is controversial. 5. Diet. TAR is a deficiency in antioxidant vitamins A, C and E, fish oil and protein. 6. Premature birth, that is small size, low birth weight, and impaired lung growth. Environmental factors include 1. Cigarette, pipe, cigar smoking, tobacco and cannabis. 2. Car exhaust pollution. 3. Industrial pollution, sulfur dioxide particulates less than 10 mm. 4. Mining of coal, silica and gold. Cadmium fumes also contribute to it. 5. Bacterial infection due to streptococcus or Haemophilus. 6. Viral infection, that is influenza, adenovirus and HIV. 7. Wood fire, that is biomass fuels. Cigar and pipe smoking are thought not to have as deleterious an effect as cigarettes, since the smoke is generally not routinely inhaled. Atmospheric pollution has been shown to have a similar though less marked effect on the FEV1 value as cigarette smoking. In emphysema, a deficiency of the enzyme alpha-1 antitrypsin has been linked to the development of the condition in both non-smokers and smokers. The enzyme antagonizes the action of proteolytic enzymes, and hence a reduction in its level allows excessive lung destruction, as shown in Figure 5. People with a deficiency of alpha-1 antitrypsin will be affected by both cigarette smoking and atmospheric pollution. Pause the video and carefully scrutinize Figure 5 illustrating the role of alpha-1 antitrypsin in COPD before advancing to the next slide. Next we will discuss its pathophysiology. Regarding chronic bronchitis, the main pathological finding is the hypertrophy of the mucus glands. There is proliferation of the goblet cells and hypersecretion of mucus. This greatly increased mucus production stimulates the cough reflex to try to clear the blockage caused by the secretions that line the bronchial tissue, contributing to the airway obstruction and wheeze. The accumulated secretions provide an excellent environment for the growth of bacteria, provoking inflammation and yet further damage to the respiratory tree. The obstruction or degree of severity increases with time, and this is consistent with the progressive nature of the condition unless remedial action is taken. The airway obstruction that is present occurs as a result of a number of factors, initially 1. Mucus blocking the bronchial tree. 2. Inflammatory narrowing. And 3. Increased bronchial smooth muscle tone. Later 1. Fibrosis of the peripheral airways. And 2. Emphysema. The airflow obstruction leads to a ventilation-perfusion imbalance with a consequent reduction in PaO2 and increase in PaCO2. In the initial stages, to overcome this problem there is reflex hyperventilation, but, as the disease progresses, the medulla becomes relatively insensitive to the hypercapnia, that is excessive carbon dioxide in the blood, and no reflex hyperventilation occurs. Simultaneously, the peripheral chemoreceptors, in both the aortic artery and carotid bodies, yield a reduced response to the hypoxemia, that is deficient oxygenation of the blood, once again reducing the degree of compensatory hyperventilation. The result of this is that the patient becomes cyanosed, and this gives rise to the name blue bloater. One further problem that occurs is the development of pulmonary vasoconstriction secondary to the decrease in PaO2, hence the resultant increased pulmonary blood pressure causes resistance to right ventricular output, leading to right-sided heart failure, that is cor pulmonale. Next we will discuss emphysema. There is an inflammatory swelling and narrowing of the bronchioles with enlargement of the alveoli and alveolar ducts. Damage to the alveoli has two main consequences. The surface area within the alveoli available for gaseous exchange is reduced, resulting in an increased dead space and impaired gaseous exchange. The elastic recoil of the small airways is reduced, leading to collapse of the small airways. As the airways become increasingly obstructed, the effort placed on the lungs increases. As the disease progresses, the FEV1 declines at a greater rate than seen with normal aging, and an imbalance between ventilation and perfusion is observed. Regarding the clinical features of emphysema, the symptoms experienced by patients with COPD will depend upon the extent of damage to the alveoli and bronchi. However, two symptoms predominate in both chronic bronchitis and emphysema, namely cough and dyspnea. Next we will discuss chronic bronchitis. The patient, usually a middle-aged man, has a cough with sputum production, coupled with some degree of bronchospasm resulting in wheeze and dyspnea. Patients often find physical exercise difficult due to worsening dyspnea. In severe disease, the chest diameter increases as the obstruction worsens. Hypoxemia increases, resulting in pulmonary hypertension, which can eventually result in cor pulmonale. Persistent lower respiratory tract infections can occur, resulting in increased volume of sputum with or without pyrexia. Unlike patients with emphysema, those with chronic bronchitis have an elevated PaCO2 above 45 mm of mercury, a reduced PaO2 below 60 mm of mercury, and a raised hematocrit 50 to 55%, which is secondary to the hypoxemia. In severe cases, the FEV1 is less than 1 liter and the FEV1 to FVC ratio is less than 30%. RV and the RV to TLC ratio are both increased in chronic bronchitis. Respiratory acidosis may occur during exacerbations. Regarding emphysema, the chief feature of emphysema is progressive dyspnea, and the typical patient will present with a long history of dyspnea. Cough and sputum are not as problematic compared to patients with chronic bronchitis. Emphysematous patients are particularly stressed during expiration. The great effort required to breathe involves the use of accessory muscles in the neck and chest wall, and as a consequence the lungs tend to become chronically overinflated, resulting in a barrel-shaped chest. Gross emphysema, with or without chronic bronchitis, is associated with irreversible airways obstruction with decreased FEV1, FVC and FEV1 to FVC ratio. Transfer factor is reduced because there is a smaller surface area available for gaseous exchange. There is increased total lung capacity and residual volume. The condition produces a ventilation-perfusion imbalance. However, when arterial blood gases are determined, PaO2 and PaCO2 levels are relatively normal. Although long-term PaO2 will fall, PaCO2 will rise and eventually cor pulmonale will develop. Bronchial infections are less common than in patients with chronic bronchitis. We will now discuss diagnosis of COPD. The diagnosis of COPD depends on thinking of it as a cause of breathlessness or cough. The diagnosis is suspected on the basis of symptoms and signs and supported by lung function tests. COPD or asthma. A differential diagnosis of asthma or COPD must be made. COPD and asthma are frequently distinguishable on the basis of history and examination in untreated patients presenting for the first time. The clinical presentations differ as shown in tables 5 and 6 below. Pause the video and carefully scrutinize table 5 summarizing the differences between COPD and asthma before advancing to the next slide. Pause the video and carefully scrutinize table 6 summarizing the differences between COPD and asthma before advancing to the next slide. Next we will discuss the assessment of COPD severity. Assessment of severity of COPD is essential to determine the prognosis and therapy for the patient. No single measure can give adequate assessment of the true severity of disease. However, the severity of airflow obstruction can be assessed according to lung function tests, particularly spirometry. This measures a number of factors which are defined below. Terms used in spirometry include 1. Forced vital capacity, abbreviated as FVC, is the maximum volume of air that can be forcibly exhaled following full inspiration. 2. Forced expiratory volume in 1 second, FEV1, is the maximum volume of air expired in 1 second following a full inspiration. 3. Peak expiratory flow rate, PEFR, is the maximum expiratory flow rate that can be sustained for 10 milliseconds following a full inspiration. The degree of airflow obstruction according to FEV1 as a percentage of the predicted value is the most important when assessing severity, as shown in Table 7 and Figure 6. Pause the video and carefully scrutinize Table 7 summarizing the assessment of the severity of airflow obstruction according to FEV1 as a percentage of the predicted value before advancing to the next slide. A firm diagnosis of COPD can only be made by objective measurement of the extent of airways obstruction by spirometry testing. The lung function values of interest in COPD are FEV1 and FVC. An FEV1 to FVC ratio of below 0.7 is indicative of COPD. If FEV1 is equal to or above 80% predicted normal, a diagnosis of COPD should only be made in the presence of respiratory symptoms, for example breathlessness or cough. Diagnosis of COPD should therefore be based on a history of typical symptoms and deviations from the predicted lung function values of FEV1 and FEV1 to FVC. Pause the video and carefully scrutinize Figure 7 summarizing the diagnosis of COPD before advancing to the next slide. Next we will discuss the management of COPD. The goals of management of COPD are to 1. Prevent symptoms and their recurrence. 2. Retard the progression of the disease. 3. Preserve optimal lung function, both in the short and long term. And to 4. Enhance quality of life. These goals may be achieved using both non-pharmacological and pharmacological methods, as summarized in figures 8 and 9 below. Pause the video and carefully scrutinize figure 8 summarizing the management of COPD before advancing to the next slide. Pause the video and carefully scrutinize figure 9 summarizing the COPD treatment as a function of lung function before advancing to the next slide. We will now discuss non-pharmacological management. Stopping smoking. 75% of chronic bronchitis and emphysema deaths are related to smoking. Health promotion for the COPD patient cannot be underestimated, and there is a role for the clinical pharmacist in this respect. Smoking cessation, be it planned or opportunistic, can have a major impact. Stopping smoking is the single most important factor affecting outcome in patients at all stages of COPD. In smokers, the rate of decline in FEV1 is 45 ml per year compared to 30 ml per year in non-smokers. Stopping smoking will reduce the rate of decline in FEV1 to that of non-smokers, and hence the rate of progression of the condition will be slowed. Patients who fail to stop smoking will have an accelerated decline in FEV1 and worsening disability will be likely. After stopping smoking, the immediate effects are, as listed below. Pause the video and scrutinize the list before advancing to the next slide. Pause the video and scrutinize figure 10 summarizing the benefits to lung function of stopping smoking before advancing to the next slide. We will now discuss avoidance of inhaled allergens. Inhaled allergens, e.g. smoky environments, may aggravate the patient's symptoms and should be avoided if possible. Regarding exercise, patients with COPD should be encouraged to exercise in order to increase their endurance and strength without worsening the dyspnea. Walking or gentle cycling should be recommended as the preferred form of exercise. Regarding diet, obese patients should be encouraged to lose weight, hence reducing the energy requirement of exercise and improving their exercise capacity. Some patients with COPD may be malnourished and should be encouraged to achieve their ideal body weight to prevent respiratory muscle dysfunction. Regarding vaccination, NICE Clinical Guideline 12 states that all patients with COPD should be offered pneumococcal vaccination and an annual influenza vaccination. Regarding physiotherapy, COPD patients with severe disease should be advised on suitable exercises to strengthen respiratory muscles and also on physical maneuvers to aid the clearance of mucus secretions. Next we will discuss the pharmacological management of COPD. None of the agents used in the management of COPD prevent the natural progression of the disease, however, they have been shown to reduce and minimize symptoms. The main drugs used in the management of the condition are relievers such as 1-beta-2 agonists, anticholinergics, and theophylline 2. Corticosteroids, and 3. Oxygen therapy. Regarding relievers, these drugs provide symptomatic treatment for the reversible component of airways obstruction and are thought to reduce bronchomotor tone and hence airway resistance in patients with COPD. They also decrease the level of pulmonary overinflation. Let's talk about beta-2 agonists. The short-acting beta-2 agonists are first-line therapy for the symptomatic management of COPD. Short-acting beta-2 agonists may be administered prior to exercise, as they increase the exercise tolerance of some patients with COPD. Long-acting beta-2 agonists in COPD can be used alone or in combination with ICS. However, the use of these agents should be limited to patients with demonstrable bronchodilator response to these agents, and their symptoms and FEV1 should be monitored. Indacaterol and olodaterol are long-acting beta-2 agonists licensed for COPD. They are not indicated for the relief of acute bronchospasm. Vilanterol is a long-acting beta-2 agonist available in a combination inhaler with fluticasone furoate, marketed as Revla Ellipta, or with umeclidinium, marketed as Anoro Ellipta. In patients with severe COPD associated with chronic bronchitis and a history of frequent exacerbations, roflumilast is licensed as an adjunct to existing bronchodilator treatment. Next we will discuss anticholinergic or muscarinic antagonists. Ipratropium bromide has been shown to be as efficacious, if not more so, than the beta-2 agonists in producing a bronchodilator response in COPD. Therefore, a COPD patient can be started on either short-acting beta-2 agonist or short-acting anticholinergic agent as required. If an anticholinergic agent fails to provide adequate symptom relief, combination therapy may be prescribed, that is, anticholinergic agent and short-acting beta-2 agonist. Use of the anticholinergic agent and the short-acting beta-2 agonist may enhance the bronchodilator response more than can be achieved by either drug alone. In fact, short-acting beta-2 agonist can be used at any stage. Long-acting anticholinergic agent and beta-2 agonist can also be used together if ICS is declined or not tolerated. Next we will discuss theophyllenes. Theophyllenes have been shown to have only a modest bronchodilating effect in COPD. Due to the narrow therapeutic range and the incidence of side effects, the value of theophylline in COPD is limited. Caution is required in elderly patients due to differences in pharmacokinetics and the likelihood of comorbidities and other medications. Treatment effectiveness should be assessed by monitoring symptoms, activities of daily living, exercise capacity and lung function. Oral theophyllenes should therefore only be added to the treatment regimen if inhaled therapies have failed to provide adequate relief or in patients who are unable to use inhalers. The theophylline dose may need to be reduced if macrolide or fluoroquinolone antibiotics are prescribed during an exacerbation. Next we will discuss corticosteroids. None of the currently available inhaled corticosteroids are licensed for use alone in the treatment of COPD. Regarding oxygen therapy, both long-term oxygen therapy, abbreviated as LTOT, and ambulatory oxygen therapy may be prescribed for patients with COPD. Trials of long-term oxygen therapy, that is oxygen provided for at least 15 hours per day, in patients with COPD have resulted in an increase in the 5-year survival rate from 25% to 41%. In order to achieve benefit in this patient group, it is recommended that oxygen is delivered for a period of at least 15 hours per day, and hence most patients with COPD will use an oxygen concentrator to deliver their oxygen. The criteria for initiating long-term oxygen therapy in this patient group are as follows: 1. PaO2 of below 7.3 kilopascals with or without hypercapnia, and an FEV1 below 1.5 liters. 2. Patients with a PaO2 value of between 7.3 and 8.0 kilopascals with evidence of pulmonary hypertension, peripheral edema or nocturnal hypoxemia. 3. Patients with a FEV1 below 1.5 liters or below 40% of predicted value. Ambulatory oxygen may also be of benefit to patients with COPD as this improves exercise tolerance and breathlessness, and may allow greater compliance and increased overall use of their oxygen therapy. There is no criteria for selecting patients who are suitable for ambulatory therapy. However, it has been suggested that prescriptions should be based on a documented fall in arterial oxygen saturation of more than 4%, below 90% on a standard walking test, and associated with an improvement in exercise tolerance or breathlessness with ambulatory oxygen therapy. Evidence to support the use of these criteria is, however, lacking. Alpha-1 antitrypsin replacement therapy. Currently, alpha-1 antitrypsin replacement therapy is not recommended in the management of patients with alpha-1 antitrypsin deficiency. Next we will discuss the management of acute exacerbations of COPD. The NICE guideline defines an exacerbation as a sustained worsening of the patient's symptoms from his or her usual stable state that is beyond normal day-to-day variation, and is acute in onset. Commonly reported symptoms are worsening breathlessness, cough, increased sputum production and change in sputum color. The change in these symptoms often necessitate a change in medication. 1. Regarding antibiotic therapy, the choice of antibiotics should follow locally produced guidelines derived from local bacteriological sensitivity data, and a maximum of 7 days treatment is sufficient. 2. Regarding oral corticosteroid therapy, the use of oral corticosteroids in managing acute exacerbations of COPD in the community is restricted to the following patient groups. 1. Patients who are already on oral corticosteroids. 2. Patients who have had a previously documented response to oral corticosteroids. 3. Patients in whom airflow obstruction fails to respond to an increase in bronchodilator dose. 4. Patients for whom this is the first presentation of airflow obstruction. Oral corticosteroids are usually given at a dose of 30 to 40 mg daily for 7 days. They should not normally be continued long-term. Patients who have been prescribed medication for an acute exacerbation of COPD should be followed up to ensure that the medication has been effective. Patients who fail to respond fully to such treatment may require a hospital referral. We will now discuss nebulizer therapy. Nebulized bronchodilator therapy is indicated for patients with distressing or disabling breathlessness despite maximal therapy using handheld inhalers. Nebulized salbutamol, dosed at 2.5 to 5 mg, terbutaline, dosed at 5 to 10 mg, or ipratropium bromide, dosed at 500 micrograms, may be given every 4 to 6 hours for 24 to 48 hours or until the patient demonstrates clinical improvement. In those patients who fail to respond to individual drug treatment, combined nebulizer treatment, 2.5 to 10 mg of a beta-2 agonist with 250 to 500 micrograms of ipratropium bromide, should be considered. There is much controversy regarding home nebulizer use for patients with COPD. The majority of patients with COPD will receive adequate bronchodilator medication from handheld inhalers. However, a few COPD patients who require large doses of inhaled medication may benefit from the use of nebulizers. Before nebulized bronchodilator therapy is initiated, the patient should be fully assessed by a respiratory physician. There is a risk that patients may become housebound due to becoming reliant on their nebulizer. This will make them deconditioned and will not aid their outcome. Next we will discuss cystic fibrosis. As a way of introduction, cystic fibrosis, abbreviated as CF, is a life-threatening genetic disorder that mainly occurs in Caucasian populations. In the UK, 9,000 people are affected by this hereditary disease. Cystic fibrosis is an autosomal recessive disease and around 1 in 25 people carry a mutation in the cystic fibrosis gene. If 2 carriers, each with 1 copy of the mutated cystic fibrosis gene, have a baby, the baby has 1 in 4 chance of developing cystic fibrosis. Cystic fibrosis is a multi-organ disease that requires input from a multidisciplinary team involving doctors, nurses, physiotherapists, pharmacists, dietitians, social workers, surgeons, psychologists and other allied healthcare staff. In addition, the family input is very significant, therefore educating family members forms a crucial part of cystic fibrosis management. Due to intensive research in the field of cystic fibrosis for over a decade, scientists are predicting the life expectancy in cystic fibrosis patients to increase to 50 years of age from the normal estimate of 30 years of age. Next we will discuss the pathogenesis of cystic fibrosis. Cystic fibrosis is caused by a mutation in the cystic fibrosis transmembrane conductance regulator, abbreviated as CFTR, gene. The gene encodes CFTR protein, which is expressed on epithelial cells and blood cells. The main function of CFTR protein is as a chloride channel, regulating transfer of chloride ions and water across the cell membrane. In cystic fibrosis, the protein encoded by the mutated CFTR gene is unable to transfer chloride ions successfully and, as a result, fluid production is reduced and of a much higher viscosity. The most commonly affected organ is the respiratory tract, whereby the fluid from the lungs is not cleared efficiently by ciliary movement of the airways. Much thicker lung fluid provides an ideal environment for bacterial growth. In addition, due to viscous and sticky bodily fluids produced in cystic fibrosis patients, organs such as the liver and pancreas can become damaged due to blockage of the bile duct and the pancreatic duct, respectively. Over 1,500 mutations have been identified in CFTR gene, however the functional effects of only a few have been demonstrated. The most common mutation is the delta F508 mutation. Mutations are classified by severity, whereby 1, 2 and 3 are considered severe cases and 4 and 5 are mild cases of cystic fibrosis. Patients are generally tested only for a few mutations, those most common for the region in which they live. CFTR protein is present in the respiratory tract, digestive tract, liver, pancreas, sweat glands and reproductive tract. Therefore, it becomes clear why cystic fibrosis affects so many organs and it is considered a multi-organ disease. Next we will discuss clinical feature of cystic fibrosis. We will begin with chronic sinopulmonary infections or reduced pulmonary function. Chronic lung infections can cause inflammation and damage to the airways. Cystic fibrosis patients tend to suffer from multi-resistant bacterial infections due to high and repeated exposure to antibiotics. Gastrointestinal and nutritional abnormalities. Cystic fibrosis can lead to blockage of the pancreatic duct, which can cause secondary damage to the pancreas, impairing its functions, such as digestion impairment due to deficiency in pancreatic enzymes and bicarbonate. Next we will discuss liver disorders of cystic fibrosis. Thick and sticky bile can lead to blockage of the bile duct, eventually causing liver cirrhosis and fibrosis. Regarding the sweat glands, increased sodium and chloride in the sweat gives the sweat a distinctive smell. A sweat test is the most important diagnostic test, where the concentration of the sodium and chloride is measured using pilocarpine iontophoresis. Male urogenital abnormalities can also occur. We will now discuss the current treatments of cystic fibrosis. Pulmonary infection prophylaxis. The most common pathogens found in cystic fibrosis patients are Staphylococcus aureus, Haemophilus influenza, Pseudomonas aeruginosa and Burkholderia cepacia. Viral infections are also common and these predispose patients to secondary bacterial infections. In order to prevent Staphylococcus aureus infections and colonization, flucloxacillin is often used prophylactically in children. Next we will discuss treatment of pulmonary infections. Regarding Staphylococcus aureus, if the patient is already on prophylactic treatment, the dose of the prophylactic antibiotic is generally doubled and given for 2 weeks. Afterwards, if the infection still persists, co-amoxiclav, trimethoprim, clarithromycin, rifampicin or clindamycin can be given for another 2 weeks. Haemophilus influenza is generally treated with amoxicillin, co-amoxiclav or cephalexin for 2 weeks or azithromycin for 1 week. Pseudomonas aeruginosa should be treated based on sensitivities. It needs to be treated aggressively and for a prolonged period of time to prevent colonization. Oral ciprofloxacin, dosed at 250 to 500 mg twice daily, and nebulized cholestyramine injections, dosed at 2 million units twice daily, are usually given for 3 months. Other alternatives include nebulized tobramycin, dosed at 300 mg twice daily. This tobramycin preparation is formulated for administration via a nebulizer. Ceftazidime and beta-lactams active against Pseudomonas aeruginosa, such as tazocin, meropenem and aztreonam, are sometimes given as a second or third-line option. In the case of Burkholderia cepacia, a sample needs to be sent off for molecular typing to determine genome var strain. Stenotrophomonas multifilia is sometimes found in cystic fibrosis patients. The significance of this is still questionable. However, it should be targeted with co-amoxiclav, co-trimoxazole, minocycline, chloramphenicol, and occasionally with nebulized colamycin. Aspergillus fumigatus may be present in the sputum and can lead to allergic bronchopulmonary aspergillosis. Next we will discuss improving lung function. Rh.D. Nase marketed as Dornase alpha pulmozyme. Dornase alpha is a genetically engineered enzyme that resembles a naturally occurring enzyme capable of cleaving neutrophil-derived DNA in sputum, thereby reducing its visco or elasticity. This enables sputum to be cleared by the mucociliary action of the airways. Pulmozyme is stored in the fridge and it should be administered undiluted using a jet nebulizer or compressor system. The dose is 2.5 mg nebulized once or twice daily. Next we will discuss about pancreatic enzymes. Due to insufficient secretion of pancreatic enzymes by the pancreas, cystic fibrosis patients should be started on pancreatic replacement therapy with pancreatin. The dose depends on the diet, and young children may require higher doses, as their diet's fat content is much higher. A typical regimen would be 3 to 4 crayon 25,000 units capsules with each meal and 1 to 2 with each snack. This regimen is adjusted according to the clinical symptoms, appearance of the stool, weight and food intake. Crayon microgranules can be mixed with meals. Most cystic fibrosis patients tend to experience malabsorption of fat-soluble vitamins such as vitamin A, D and E due to pancreatic insufficiency. These vitamins should be supplemented as per local guidelines. Generally, vitamin A is given at the dose between 4,000 to 10,000 units per day, vitamin D 400 to 800 units per day, and vitamin E 150 to 300 units per day. Next we will discuss diabetes. Cystic fibrosis-related diabetes is quite different from juvenile diabetes with regards to the way insulin is secreted. Cystic fibrosis patients tend to have a delayed but not necessarily insufficient insulin secretion. However, with progressive loss of pancreatic function, diabetes can become symptomatic and insulin dependent. Insulin requirements tend to be lower than in juvenile diabetes. Depending on the degree of pancreatic damage, patients may suffer from impaired glucose tolerance only. Patients should be treated as early as possible to improve their quality of life and life expectancy. Next we will talk about bone disease. Bone disease may develop in cystic fibrosis patients for several reasons, including 1. Low bone formation due to cellular dysfunction. 2. Malabsorption of vitamin D and K3. Poor diet. 4. Low calcium intake. 5. Frequent courses of steroids. 6. Lack of exercise. 7. Cystic fibrosis-related diabetes. And 8. Immune system-mediated condition related to chronic airway inflammation and infection. Regarding immunization, cystic fibrosis patients should be immunized properly due to the frequent occurrence of bacterial, viral and fungal infections. Patients are very likely to miss national immunization programs at school or with the GP, as they are in and out of the hospital very frequently and looked after by a specialist. The additional vaccines that cystic fibrosis patients should potentially have besides regular immunization include hepatitis A and B, varicella zoster, pneumococcal, meningococcal, and annual influenza. Respiratory syncytial virus, abbreviated as RSV, is common in cystic fibrosis patients and can play a critical role in Pseudomonas colonization and subsequent decline in pulmonary function. Palivizumab is a monoclonal antibody indicated for the prevention of serious lower respiratory tract infections caused by RSV. The dose is 15 mg per kilogram once a month, normally given during the RSV season, which is from September to May. A maximum of 5 injections is given per season. And now we will address the question, what does the future hold? There is a lot of research going on in the cystic fibrosis field, from development of gene therapy to management of pulmonary infections, malabsorption and difficulty in digestion. There are a few clinical trials that are investigating the best combination, duration and frequency of antibacterial administration. Management of multiresistant variant of Pseudomonas aeruginosa, MRSA, and Burkholderia cepacia are also being investigated in the trials. New and improved devices are being developed for more efficient administration of drugs by nebulization or inhalation, and new formulations of antibiotics are manufactured to make the administration easier. As Pseudomonas aeruginosa is the most common pathogen in cystic fibrosis patients, vaccines are being developed to prevent infection, however the results are still to be determined. Anti-inflammatory agents in clinical trials targeted at reducing lung inflammation include serine protease inhibitors, ibuprofen, various combinations of glucocorticoids, and other agents such as montelukast, azithromycin, and others. There is a need for better preparations of pancreatic enzymes that can withstand acidic environment and malabsorption issues. With regards to cystic fibrosis-related diabetes, the best time to start treatment is it is still not clear, and if oral hypoglycemics can be used. This needs to be investigated further. There are various agents being developed for improvement in the mucociliary clearance. These include activator of the calcium-dependent chloride channels, Moly-1901, UTP analogues, and the benefit of pulmozyme on pulmonary function and exacerbations is being investigated. Finally, the principles of gene therapy involve mutant CTRF cell transfection with wild-type CTRF. This looks like a very promising field of research, however, better vectors are needed to show desirable functional effects of gene therapy. Next we will discuss lung cancer. We will begin by looking at lung cancer epidemiology. Incidence and mortality attributed to lung cancer has risen steadily since the 1930s, predominantly due to the increase in cigarette smoking. Since then, lung cancer has become a global problem. 6 million new cases are diagnosed with lung cancer every year worldwide, and it represents just over 10% of all cancer diagnoses. Lung cancer is more common in men and women, and it accounts for more deaths than any other cancer in both men and women. The one-year survival in lung cancer patients has increased from 35% in late 1970s to 42% in 2008. The overall 5-year survival is one of the lowest amongst cancers, and it was reported to be 16.8% in 2005 based on the National Cancer Institute statistics in 2005. Also, 5-year survival in women is better than in men regardless of histological type. The most common risk factors are 1. Smoking. Around 90% of lung cancers in men are caused by smoking. Polycyclic aromatic hydrocarbons, carcinogenic compounds present in tobacco smoke, cause mutations in p53, which is the most common mutation in cancer. 2. Radon, inhaled or from the soil. Underground miners are at particular risk. 3. Second-hand smoke exposure. 24% increased lung cancer risk has been shown in non-smokers who have lived with a smoking spouse. 4. Other environmental factors such as occupational exposure, asbestos being the most common carcinogen closely linked to lung cancer and mesotheliomas. There are two most common types of lung cancer, namely 1. Non-small cell lung cancer, abbreviated as NSCLC, and 2. Small cell lung cancer. Next we will discuss lung cancer complications. We will begin with shortness of breath. This occurs as a result of the tumor growing and blocking the major airways, or as a result of fluid accumulation in the lung causing difficulties for lung to expand during inhalation. Next we will talk about coughing up blood, also referred to as hemoptysis. Lung cancer can cause bleeding in the airways. It is one of the initial symptoms, and bleeding can actually become very severe and require treatment. Next we will look at chest pain or other constant pain. Pain starts as the tumor grows and spreads into the lining of a lung, airway or chest wall. Other types of pain such as bone pain can be the result of the cancer spreading to other parts of the body. The pain doesn't have to be strong, but if it is constant it may indicate that there is cancer growth and spread. Regarding pleural effusion, lung cancer can cause accumulation of the fluid in the pleural space. Next we will consider metastasis. Any cancer has the ability to spread to other parts of the body via host vasculature, but certain cancers tend to migrate to specific parts of the body. Lung cancer commonly migrates into the lymph nodes within the chest, or in the abdomen, the neck or armpit, the liver, the bones, the brain and the adrenal glands. Headache, drowsiness, nausea and vomiting are other symptoms that could be associated with lung cancer metastases. We will now discuss the commonly used treatments. Small cell lung cancer is generally treated with chemotherapy. It is a more aggressive form of lung cancer, therefore surgery is only warranted if the tumor has not spread to the lymph glands in the center of the chest, which is commonly the case at diagnosis. Radiotherapy might be used. Non-small cell lung cancer can be treated with surgery, chemotherapy, radiotherapy or a combination of these, depending on the stage when the cancer is diagnosed. Some people with advanced lung cancer may have biological therapy. Recent advances in identifying novel molecular targets and biomarkers of response to anti-cancer agents in lung cancer are responsible for some improvement in the prognosis. Epidermal growth factor receptor, abbreviated as EGFR, Kirsten rat sarcoma viral oncogene homologue, abbreviated as KRAS, and anaplastic lymphoma kinase, abbreviated as ALK, mutations have been recently discovered as viable targets expressed in certain lung cancers, and drugs targeting these proteins have shown promise in the treatment of lung adenocarcinoma. EGFR tyrosine kinase inhibitors, gefitinib, erlotinib and afatinib are biological therapies available for the treatment of lung cancer which overexpresses EGFR. Crizotinib is used in lung cancer with overexpressed ALK protein. Currently, NICE is preparing guidelines on nintedanib for treating previously treated metastatic non-small cell lung cancer. Anti-angiogenic agents bevacizumab and cetuximab are also used in non-small cell lung cancer. Treatments such as bronchodilators, oxygen and other relevant treatments for complications of lung cancer are also employed. Ref. NICE Guidelines on Lung Cancer, Diagnosis and Management 2011. Next we will discuss upper respiratory tract infections. Traditionally the respiratory tract has been subdivided into the upper and lower regions, above and below the epiglottis, and infection in these two regions dealt with separately. In healthy people, most of the time, the upper respiratory tract has a rich and varied microbial flora, whereas the lower region is largely free from microorganisms due to the protection afforded by the ciliated epithelium, mucus and macrophages therein. However, some microbes are implicated in several infectious diseases of the respiratory tract, and there is considerable overlap in microorganisms between upper and lower tract disease. Bacteria and/or viruses cause respiratory infections. If the disease is diagnosed as being caused by a virus only, an antibiotic will be useless. Bacteria may be involved, though this may be difficult to recognize. Secondary bacterial infection is frequently present in otitis media, sinusitis and pneumonia, in which cases antibiotics should be prescribed. Antibiotic therapy for conditions such as pharyngitis, sore throat, and croup are more controversial. The 1998 report of the Standing Medical Advisory Committee on Antimicrobial Resistance highlighted the growing and alarming problem presented by inappropriate and overprescribing of antibiotics. In England alone, over 50 million prescriptions are dispensed for antibiotics, of which about 80% are for oral antibiotics in the community. About half of this community use is in respiratory tract infection. Hospital prescribing accounts for only 20% of antibiotic usage, but, as it is concentrated in a small population in confined areas and contains large numbers of immunocompromised patients, it is of a major importance with respect to antibiotic resistance. Two of the four major areas identified in the report as providing opportunity for making a significant impact on the volume of antibiotics prescribed were no prescribing of antibiotics for 1. Simple coughs and colds and 2. Viral sore throats. The ability of the mucosal epithelium to resist microbial adherence through mucociliary clearance is a major factor in elimination of microorganisms. In spite of this, the average person has 5 upper respiratory tract infections per year, and up to 12 such infections in young children is not uncommon. However, the majority of these will be common colds, that is coryza, requiring little or no treatment. Fortunately, most respiratory tract conditions begin and remain upper respiratory tract infections. Upper respiratory tract infections are viral in origin in more than 90% of cases. Antibiotics are only indicated if a bacterial cause is found, the illness is severe, or if a primary viral infection has given rise to bacterial superinfection. Antibiotics are also useful for the prevention of bacterial complications of influenza in patients with severe underlying chest disease. Bacterial infection is suggested by 1. Purulent secretions from an inflamed mucosa. 2. Predominance of a potential pathogen in cultures taken from a patient not in receipt of antibiotics. 3. Painful regional lymphadenitis. And 4. No connection with a known viral epidemic. Viral infection is generally characterized by 1. Rhinitis. 2. Bilateral catarrhal conjunctivitis. 3. Non-suppurative pharyngitis. 4. Vesiculation. 5. Swelling of the follicles. 6. Tracheitis with a dry cough, particularly with influenza. 7. Generalized lymphadenopathy. 8. Non-specific rash. 9. Myalgia or a normal peripheral white cell count. Respiratory infections of bacterial and viral origin cannot reliably be distinguished by clinical or hematological findings. Table 8 summarizes the antibiotics used on the occasions where bacterial infection is diagnosed in upper respiratory tract infections. Further discussion of this aspect is presented under the management of particular diseases. Pause the video and carefully scrutinize Table 8 summarizing antibiotics employed for bacterial infection of the upper respiratory tract before advancing to the next slide. Next we will discuss adverse respiratory effects of antibiotics. The normal respiratory tract may be adversely affected by many antibiotics. Sensitized individuals may suffer hypersensitivity reactions resulting in bronchial asthma or pulmonary eosinophilia. Those patients who have an underlying bronchospastic tendency are most likely to exhibit asthmatic reactions induced by drugs such as nitrofurantoin, para-aminosalicylic acid, the sulfonamides and beta-lactam antibiotics. Nitrofurantoin has also been associated, on long-term use, with chronic interstitial pneumonitis progressing to fibrosis. Patients receiving cytotoxic or immunosuppressive therapy are vulnerable to side effects of antibiotic therapy where the normal flora becomes disturbed and opportunistic lung infection occurs. There is also a risk of neutropenia. Next we will discuss pharyngitis, that is sore throat, tonsillitis. This is usually viral in origin, so antibiotics are generally not required. However, pharyngitis is one of the most common problems seen in general practice and also one of the most controversial. Different surveys have said that the cause can be bacterial, Streptococcus pyogenes, in perhaps 20% to 50% of cases. The adenoviruses account for most of the others. As there are many antigenic strains, exposure to one strain provides little protection from others. Regarding its treatment, streptococcal sore throat is important because it may lead to serious complications. Antibiotic treatment of streptococcal sore throat will prevent subsequent rheumatic fever, which may follow in 0.4% to 2.8% of untreated cases. The antibiotic of choice is either phenoxymethylpenicillin or, for penicillin hypersensitive individuals, erythromycin or cephalexin. It is recommended that these be given for at least 10 days to eradicate the organism. Ampicillin should not be used as it is less active than benzylpenicillin and it will cause a rash if the sore throat is the beginning of glandular fever. Tetracyclines are also unsuitable because they are not bactericidal, they carry a greater risk of side effects and there is a higher incidence of resistance among streptococcal strains, 30 to 40%. Penicillin lozenges, not available in the UK, should not be given because of the risk of allergy. Topical treatment with antiseptics is ineffective and does not prevent the serious complications of streptococcal infection. Next we will discuss laryngitis and acute epiglottitis, also known as croup. Laryngitis is usually associated with acute tracheitis in adults, that is hoarseness and a barking cough. This is generally as a result of viral infections, measles, influenza, and adenovirus, and very rarely as a primary or secondary bacterial infection caused by Haemophilus influenza, streptococci, pneumococci, and staphylococci. Treatment is supportive as the condition is usually self-limiting, resolving itself in 2 to 4 days. The presentation in children is as an acute epiglottitis with a rapid onset. This dangerous condition is caused by infection with Haemophilus influenza of serotype B. Complete airway obstruction can occur with dramatic suddenness. Treatment is as much concerned with maintaining the airway as with controlling the infection. As soon as the infection is diagnosed, treatment should be started with parenteral chloramphenicol or, if not available, intramuscular ampicillin. In areas where resistant strains are known to be prevalent, cefotaxime or cefuroxime offer a logical alternative. Next we will discuss rhinitis, acute otitis media and sinusitis. A common accompaniment of most viral upper respiratory infections is mild catarrhal inflammation that spreads up the eustachian tubes and into the paranasal sinuses. This often resolves without therapy as the cold recedes. More severe illness with facial pain and tenderness, a purulent nasal discharge or earache indicates bacterial infection and demands antibiotic treatment. Regarding the treatment, acute sinusitis and acute otitis media are both caused predominantly by Haemophilus influenza and Streptococcus pneumoniae. Streptococcus pyogenes and staphylococci are less often involved. Amoxicillin is the antibiotic of choice with erythromycin and co-trimoxazole as alternatives if beta-lactamase-producing Haemophilus influenza is involved. 10-day treatment is generally given but may vary between the practices. Use of analgesics, decongestants and humidification are helpful. Next we will discuss Candida stomatitis, also referred to as thrush. Thrush presents as a whitish, removable membrane due to infection by the yeast Candida albicans on the oral mucosa, in the absence of fever. It is predominantly a neonatal infection when the treatment is with local nystatin. Oral thrush commonly occurs in patients using inhaled steroids. However, in adults not receiving such therapy, oral thrush is more sinister and almost always indicative of serious underlying endocrine disorders such as uncontrolled diabetes mellitus or suppression such as that caused by acquired immunodeficiency syndrome (AIDS). The fungal infections that frequently accompany these situations are categorized as opportunistic mycoses. If they are not rapidly diagnosed, aggressively managed and the underlying disorders brought under control, the infections become life-threatening. Next we will discuss its treatment. Treatment is generally topical with nystatin, meconazole, clotrimazole, fluconazole or amphotericin B as lozenges, mouthwash or oral gel. Systemic treatment with ketoconazole, 200 to 400 mg in adults, may be given once a day until at least 1 week after symptoms have resolved and cultures have become negative. And now we will proceed to lower respiratory tract infections. Let's begin with their pathophysiology. These are almost always associated with some disorder of the normal mechanisms of resistance, ciliary activity, mucus secretions, alveolar phagocytosis, cough reflex, IgA, Ig, E, Ig, G, lysozyme, white cell function. This protective system can be disrupted by viral infection, chemical or physical damage, aspiration or the presence of a foreign body. The bronchial mucosa is normally sterile and pathogens must be distinguished from commensal mouth bacteria when expectorated sputum is examined. This is often difficult and can give rise to misinterpretation of culture results. Antibiotics may alter the flora and further complicate the picture. If the sputum is macroscopically purulent, microscopic examination of a gram-stained fleck of pus may help the interpretation of results. However, pneumococci are often indistinguishable from heavy oral contamination with commensal viridans streptococci by this method. Next we will discuss the whooping cough. Whooping cough is caused by Bordetella pertussis bacteria. It is a catarrhal illness followed by paroxysms of coughs, which is further followed by a whoop sound due to inspiratory gasp of air. It can last for weeks. Lobar or segmental collapse of the lungs can occur. It can lead to exhaustion and secondary pneumonia. Some fatal outcomes have been reported. The bacteria attach to respiratory epithelium and it is spread from person to person by airborne droplets. All children up to the age of 10 years should receive primary immunization with diphtheria, tetanus, pertussis, poliomyelitis and Haemophilus type B conjugate vaccine. A booster dose of an acellular pertussis-containing vaccine should ideally be given 3 years after the primary course, although, the interval can be reduced to 1 year if the primary course was delayed. In response to a pertussis outbreak in 2012, the UK Department of Health introduced a temporary program to vaccinate pregnant women against pertussis. This program will continue until at least 2019. The aim of the program is to boost the levels of pertussis-specific antibodies that are transferred through the placenta, from the mother to the fetus, so that the newborn is protected before routine immunization begins at 2 months of age. Pregnant women should be offered a single dose of a cellular pertussis-containing vaccine, diphtheria, low-dose, tetanus, pertussis and poliomyelitis vaccine, Boostrix IPV, between 28 to 38 weeks of pregnancy. The optimal time for vaccination is between 28 to 32 weeks of pregnancy. Next we will discuss community-acquired pneumonia, also known as CAP. Pneumonia is an inflammation of the lower air passages and alveoli of the lungs resulting from infection of the parenchyma of the lungs. The main forms of pneumonia are 1. Bronchopneumonia, where the consolidation is patchily distributed in a lobular pattern throughout the lung fields, especially in babies and the elderly. 2. Lobar pneumonia, where the consolidation may be confined to part or the whole of one or more lobes of the lungs. 3. Interstitial pneumonia observed with viral infection, mycoplasma infections, ornithosis and Q fever. This is often referred to as atypical pneumonia. 4. Lung abscess, sometimes referred to as necrotizing pneumonia, is a condition in which there is cavitation and destruction of the lung parenchyma, mostly of bacterial origin. Genuine viral pneumonia without bacterial involvement is rare and usually associated with influenza, measles adenoviruses, respiratory syncytial viruses, also known as RSV, and with varicella. Alterations in the normal oropharyngeal flora, Streptococcus pneumoniae, Klebsiella pneumoniae, Peptococcus species, Fusobacterium species, Bacteroides species, may occur due to, e.g., broad-spectrum antibiotic usage, with colonization by pathogenic gram-negative bacteria, also known as GNB, and Staphylococci. Aspiration of gram-negative bacteria in oropharyngeal secretions with rapid colonization of the lower respiratory tract can also occur in the hospital environment in patients with loss of the gag reflex, e.g. alcoholics, stroke victims, head injury patients or patients receiving general anesthetics. This is sometimes referred to as aspiration pneumonia. Age is also important. The elderly may have impaired mucociliary clearance mechanisms and a lower cell-mediated immunity. In the ICU, the use of endotracheal and nasogastric tubes has been shown to predispose patients to pneumonia. The term hospital-acquired pneumonia is often ascribed to this condition, as opposed to the community-acquired pneumonias shown later. A specific microorganism may be identified in a patient suffering from pneumonia, however, this is usually not the case. Correlation between a particular form of pneumonia and a given pathogen is closest in primary pneumonia, Streptococcus pneumoniae. The clinical picture of the more common secondary pneumonias is changed considerably by the primary disease and factors that lower resistance such as cystic fibrosis, mitral valve disease, heart failure, etc. The most commonly occurring bacteria in CAP are shown in Table 9. Pause the video and carefully scrutinize Table 9 summarizing the commonly occurring bacteria in CAP before advancing to the next slide. Although Staphylococcus aureus and gram-negative enteric bacilli are uncommon in CAP, they carry high mortality and patients should be treated with appropriate antibiotics, taking potential resistance into consideration. Studies of CAP from different countries have used very different definitions and inclusion criteria. Most have required a combination of symptoms, signs, and radiological features. The British Thoracic Society (BTS) defines CAP in patients admitted to hospital as 1. Symptoms and signs consistent with an acute lower respiratory tract infection associated with new radiographic shadowing for which there is no other explanation, e.g. not pulmonary edema or infarction. 2. The illness is the primary reason for hospital admission and is managed as pneumonia. Regarding its clinical features, typical symptoms that CAP patients present with include 1. Cough. 2. Purulent sputum. 3. Fever. 4. Pleuritic pain. And 5. Breathlessness. Atypical pneumonia is characterized by extrapulmonary symptoms, confusion, and diarrhea, little or no sputum and dry cough. Generally, there is no evidence of lobar consolidation. The initial diagnosis of CAP generally includes assessment of the severity and the patient's circumstances, which guides the decision on the type and the way the patients are treated. Next we will discuss the investigations. General investigations include chest X-ray, full blood count, urea, electrolytes, liver function tests, C-reactive protein, oxygen saturation and arterial blood gases assessment. Microbiological investigations include blood culture, sputum culture and sensitivity. Specific investigations for Legionella and pneumococcus may be requested depending on the severity and the history. Next we will discuss severity assessment. The British Thoracic Society recommends the use of the CAB-65 model as a mean of predicting mortality and hence stratifying patients into different treatment pathways. No predictive model allows the unequivocal categorization of patients into definite risk groups and they should be regarded as an aid to clinical judgment. Regular reassessment of severity during the course of illness is mandatory if management is to be adjusted appropriately. Next we will discuss the CAB-65 severity assessment model. It assigns 1 point for each of the following: 1. Confusion, that is new disorientation in person, place or time. 2. Urea above 7 mmol per liter. 3. Respiratory rate equal to or above 30 breaths per minute. 4. Blood pressure with systolic below 90 mm of mercury and diastolic equal to or less than 60 mm of mercury. It assigns 1 point each to these. And age equal to or above 65 years. Pause the video and examine the table illustrating the CAB-65 scoring system. Other factors to be taken into account together with the CAB-65 score include the stability of comorbid diseases and social circumstances. One must be very careful when interpreting the CAB-65 score and clinical judgment should be fully utilized. Next we will discuss treatment. General treatment goals for patients admitted to the hospital with CAP should include the following: 1. Oxygen should be given to maintain PaO2 equal to or above 8 kPa and oxygen saturation between 94 and 98%. 2. Intravenous fluids might be required according to the patient's fluid status. 3. Deep vein thrombosis prophylaxis should be given, e.g. enoxaparin 40 mg subcutaneously once a day. 4. Nutritional support, and 5. Chest physiotherapy, e.g. for expectoration of the sputum, and mobility. A major problem with the treatment of CAP is overprescribing and inappropriate prescribing of antibiotics. These factors lead to antibiotic resistance and increase the rate of Clostridioides difficile occurrence. As Streptococcus pneumoniae is one of the most common pathogens in CAP, there is increasing concern about developing resistance as a result of overprescribing of antibiotics. Nevertheless, it is very important that the severity of CAP is determined quickly and that the patient is treated adequately. Microbiological results will influence the antibacterial treatment. However, the BTS recommends that patients should receive antibiotics promptly, as this is very important for the outcome of CAP. Normally, treatment will be dictated by the local antibiotic formulary. BTS guidelines for empirical treatment in non-severe, hospital-treated CAP are provided in Table 10. Pause the video and carefully scrutinize Table 10, which summarizes empirical antibiotic choice for non-severe hospital-treated CAP before advancing to the next slide. In low-severity CAP, amoxicillin 500 mg thrice daily orally should be sufficient. However, in moderately severe CAP, that is CAB-65 score of 2+, other moderate clinical symptoms, clarithromycin should be added to amoxicillin 1 gram thrice daily orally. Monotherapy with a macrolide can only be given if previous treatment with amoxicillin failed, however this is difficult to determine and therefore dual therapy is a safer option for the initial treatment. There is a risk of QT prolongation with a macrolide or fluoroquinolone combination. As mentioned above, moxifloxacin should be used only as a last resort due to hepatic adverse effects. BTS guidelines for empirical treatment in severe, hospital-treated CAP are provided in Table 11. Pause the video and carefully scrutinize Table 11, which summarizes empirical antibiotic choice for severe hospital-treated CAP before advancing to the next slide. If Legionella is strongly suspected, levofloxacin should be added sooner rather than later. Cephalosporins and fluoroquinolones should only be used if there is no other choice and the patient is severely allergic to penicillin, as they are considered to be associated with the occurrence of Clostridioides difficile more than co-amoxiclav and benzylpenicillin. Also, transition from intravenous to oral administration is more straightforward when co-amoxiclav is used. Most importantly, co-amoxiclav has excellent cover against Streptococcus pneumoniae, Staphylococcus aureus and Haemophilus influenza. Patients treated initially with parenteral antibiotics should be transferred to an oral regimen as soon as is clinically appropriate, and their temperature has been normal for 24 hours providing there are no contraindications to the oral route as shown in Table 12. Clinical pharmacists are in a very good position to monitor treatment and point out to doctors when the intravenous route has been used for too long. Pause the video and carefully scrutinize Table 12, which summarizes step-down or switch antimicrobial recommendation before advancing to the next slide. The duration of antibiotic treatment will be between 7 days in non-severe cases and 10 days in severe CAP. Duration may be extended further depending on the pathogen involved or if there are any complications experienced by the patient, e.g. lung abscess or pleural effusion. Next we will discuss monitoring in the hospital. The following parameters should be monitored at least twice a day. 1. Temperature, respiratory rate, pulse, blood pressure, oxygen saturation and MEW score, which stands for Modified Early Warning score. 2. C-reactive protein (CRP) and chest radiography should be monitored if no improvement in condition is seen. CRP is often a more sensitive marker of pneumonia than WBC and it should generally fall by at least 50% after 4 days of treatment. Patients should be suitable for discharge only if no more than one of the following are present 24 hours before anticipated discharge: temperature above 37.8 degrees Celsius, heart rate above 100 beats per minute, respiratory rate above 24 breaths per minute, systolic blood pressure below 90 mm of mercury or oxygen saturation below 90%. We will now discuss pneumococcal pneumonia. The most common cause of lobar pneumonia in previously healthy adults and children is the pneumococcus bacteria. Patients with pneumonia require treatment before the results of bacterial investigation are known. The following recommendations are taken from the British Thoracic Society Guidelines for Community-Acquired Pneumonia 2011 Update 1. Only a small number of pathogens cause CAP, with Streptococcus pneumoniae, and Haemophilus influenza being the most common. 2. The causative organism is not identified in approximately 40% of sputum samples taken in patients with CAP. 3. Only in those with severe illness, where the frequency of Legionella and staphylococcal infection is higher, may inquiry about foreign travel or influenza be of a predictive value. 4. Knowledge of increased mycoplasma activity in the community during an epidemic period may be of help to guide the clinician to the increased likelihood of mycoplasma infection. And 5. Elderly patients are more likely to present with nonspecific symptoms and are less likely to have fever than younger patients. Next we will discuss staphylococcal pneumonia. This tends to cause multiple abscesses of the lungs and often pneumothorax and septicemia. It is uncommon except during epidemics of influenza and occurs particularly in infants and patients with impaired immunity or underlying diseases such as cystic fibrosis, thrombophlebitis associated with venous catheters and heroin addiction. Regarding its treatment, any patient in the above categories who becomes rapidly and gravely ill with pneumonia should be assumed to have a staphylococcal infection and should be treated with large doses of a penicillinous stable penicillin, preferably flucloxacillin. Next we will discuss Legionnaire's disease. Legionella pneumophila, identified in 1976 from a small, severe pneumonia epidemic in Philadelphia, accounts for 10% or more of lobar pneumonia cases in some series. It can occur in explosive outbreaks but is more commonly sporadic. Several hospital outbreaks of legionellosis have been described which have particularly affected elderly patients with extensive underlying disease or impaired resistance. More than half of the cases diagnosed in the UK are found retrospectively by antibody studies on follow-up after recovery from acute illness. Legionella pneumophila urine antigen test is not sufficiently sensitive for Legionnaire's disease and therefore, if it is strongly suspected, treatment should not be stopped based on urine antigen test only. Patients whose pneumonia is caused by Legionella bacterium are very likely to have a severe case of pneumonia and to be at high mortality risk. Regarding its treatment, penicillins, cephalosporins and aminoglycosides are all ineffective in Legionella infection. Clarithromycin is the antibiotic of choice. This is usually given with rifampicin in proven cases of Legionella pneumonia. Next we will discuss hospital-acquired pneumonia, also known as HAP. Hospital-acquired pneumonia and ventilator-associated pneumonia, also called VAP, remain important causes of morbidity and mortality despite advances in antimicrobial therapy, better supportive care, and the use of a wide range of preventive measures. The American Thoracic Society provides the following definitions. Hospital-acquired pneumonia is defined as pneumonia that occurs 48 hours or more after admission, which was not incubating at the time of admission. Hospital-acquired pneumonia may be managed in a hospital ward or in the intensive care unit when the illness is more severe. Hospital-acquired pneumonia occurs in just under 2% of patients admitted to hospital and increases the length of stay by around 8 days in the UK. Ventilator-associated pneumonia refers to pneumonia that arises more than 48 to 72 hours after endotracheal intubation. Almost half of intubated patients develop ventilator-associated pneumonia 4 days after intubation. On average, ventilator-associated pneumonia occurs in 20% of all intubated patients and it increases length of stay by an average of 6 days in the UK. Although not included in this definition, some patients may require intubation after developing severe ventilator-associated pneumonia and should be managed similar to patients with ventilator-associated pneumonia. Hospital-acquired pneumonia requires the entry of microbial pathogens into the lower respiratory tract, followed by colonization, which can then overwhelm the host's defenses to establish infection. Sources of infection for hospital-acquired pneumonia include healthcare devices or the environment, air, water, equipment, etc., and can occur with transfer of organisms between staff and patients. Host factors, such as the severity of the patient's underlying disease, prior surgery, exposure to antibiotics, other medications, and exposure to invasive respiratory devices and equipment, are important in the pathogenesis of hospital-acquired pneumonia and ventilator-associated pneumonia. Hospital-acquired pneumonia and ventilator-associated pneumonia may be caused by a wide spectrum of bacterial pathogens and, rarely, viral or fungal pathogens in immunocompromised patients. Common pathogens include Pseudomonas aeruginosa, Escherichia coli, Klebsiella pneumoniae and Acinetobacter species. Infections due to Staphylococcus aureus, particularly methicillin-resistant Staphylococcus aureus (MRSA), are becoming more common, particularly in intensive care units (ICUs). Polymicrobial infection may occur and is often present in patients with adult respiratory distress syndrome (ARDS). The incidence of hospital-acquired pneumonia due to multi-drug-resistant pathogens has increased in recent years, particularly in the ICU. The frequency of specific multi-drug-resistant pathogens causing hospital-acquired pneumonia varies by hospital, patient population, exposure to antibiotics, type of ICU patient, and changes over time, emphasizing the need for up-to-date local surveillance data. Next we will discuss the risk factors for hospital-acquired pneumonia. Patients' concurrent diseases seem to be the most influential factors for development of hospital-acquired pneumonia. These include alcohol misuse, malnutrition, diabetes, cardiovascular disease, COPD, elderly patients, splenectomy patients, patients with impaired swallowing, e.g. neuromuscular, esophageal disease, and impaired conscious. ICU patients, when given antacids, or PPIs, and antihistamines, could be at a greater risk of developing hospital-acquired pneumonia, therefore sucralfate might be a better option as it does not decrease the acidity or volume of the gastric acid. However, this should only be implemented in patients with low risk of bleeding as sucralfate is inferior to PPIs in preventing gastrointestinal bleeding. We will now discuss their antibiotic treatment. Normally, treatment will be dictated by the local antibiotic formulary. The American Thoracic Society has produced guidelines for the antibiotic treatment of hospital-acquired pneumonia and ventilator-associated pneumonia. The guidelines emphasize 1. The use of early and appropriate therapy, in correct doses. 2. Avoiding excess use of antibiotics and de-escalating the initial therapy based on culture results and the patient's clinical response. 3. Limiting the duration of therapy to the minimal effective period of time. The key decision in initial empiric therapy is whether the patient has risk factors for multi-drug-resistant MDR pathogens, as shown in Figure 11. Recommended antibiotics are shown in tables 13 and 14. Pause the video and carefully scrutinize Figure 11 illustrating an algorithm for initiating empiric antibiotic therapy for hospital-acquired pneumonia and ventilator-associated pneumonia before advancing to the next slide. Pause the video and carefully scrutinize Table 13 summarizing initial empiric therapy in patients with no known risk factors for MDR pathogens, early onset and any disease's severity before advancing to the next slide. Pause the video and carefully scrutinize Table 14 summarizing initial empiric therapy in patients with late onset or risk factors for MDR pathogens and any disease severity before advancing to the next slide. And now we will discuss tuberculosis. Tuberculosis (TB) is an infection caused by Mycobacterium tuberculosis. Tuberculosis infection is that state in which the bacillus is present in the body but is asymptomatic. Tuberculosis exists when the disease becomes evident clinically, radiologically or bacteriologically. Regarding the etiology and pathogenesis of tuberculosis, the most common means of spreading tuberculosis between individuals is by droplet infection. The airborne droplets contain the bacilli which are inhaled and lodge in the respiratory tract. As the bacillus is anaerobe, the high oxygen tension in the lung will provide an ideal environment for growth, hence pulmonary tuberculosis is the most common form of the disease. However, it may spread to any organ in the body but is more common in those with higher oxygen tensions such as the kidney and brain. Primary tuberculosis is the name given to the initial infection, which occurs almost exclusively in the lungs. Organisms will multiply rapidly in the lungs and spread to the lymph nodes and the blood stream, thus, having been distributed, organisms can remain viable but dormant for many years. This primary infection is usually controlled by the host's immune system, with the bacteria becoming engulfed by macrophages and being effectively walled off by the production of fibrotic tissue and calcification. In the majority of cases, the complex heals. Occasionally, pulmonary complications follow such as progressive pulmonary tuberculosis, lobar collapse, tuberculous pleurisy, or hematogenous spread occurs, that is miliary tuberculosis, tuberculous meningitis, bone and joint tuberculosis or genitourinary tuberculosis. Post-primary tuberculosis is caused by reactivation of a previous lesion and is usually localized as the host's immune system is already sensitized. The most common site is the lungs. Next we will discuss the incidence of tuberculosis. TB worldwide is a massive problem. In the UK, cases of TB fell from 50,000 per year in the 1950s to a low 5,800 in the late 1980s. The epidemiology of TB in the UK also changed from a disease of the general population to one of predominantly high-risk groups. In the UK, cases started to rise in the early 1990s and around 9,000 new cases were reported in 2010. The increases have been greatest in urban areas, particularly in London, whereas TB has declined in most rural areas. The 1998 National Survey of Tuberculosis in England and Wales confirmed a continuation of the trend for increasing numbers of cases in minority ethnic groups such as those of Indian subcontinent and Black African origin. Notification rates in these groups remain very high. Approximately 70% of reported cases are in people not born in the United Kingdom. HIV continues to contribute to tuberculosis case numbers. At least 3% of tuberculosis cases in 1998 were estimated to be HIV infected. Drug resistance remains an important issue. Predisposing factors to the development of tuberculosis include 1. Living conditions. 2. Nutrition. 3. Coexisting disease states, e.g. diabetes mellitus, or alcoholism. 4. Smoking. 5. Corticosteroid therapy. And 6. HIV infection. We will now discuss the signs and symptoms of tuberculosis. Primary tuberculosis is an asymptomatic condition that usually will resolve spontaneously. Post-primary tuberculosis is different, with its onset being slow and insidious. The symptoms, when they occur, are usually non-specific and can include those listed below. 1. Anorexia. 2. Malaise. 3. Chronic cough. 4. Hemoptysis. 5. Weight loss. 6. Fever. 7. Night sweats. And 8. General debility. Other symptoms may include pleuritic pain, dyspnea and frequent colds. The very general nature of these symptoms makes diagnosis difficult. Next we will discuss investigations. Regarding bacteriological investigations, isolation of Mycobacterium tuberculosis from an infected site provides positive proof of the presence of the disease. Generally, sputum is the main source of the bacillus in pulmonary infection, although occasionally it is found in bronchial washings obtained at bronchoscopy. At least 3 early morning sputum samples should be sent for bacillus isolation, and in addition, if the patient produces a spontaneous sputum sample, it should also be sent. The bacilli do not stain easily, but once stained they are both acid and alcohol resistant, hence the name AAFB, which stands for acid and alcohol fast bacilli. Treatment should not be delayed whilst awaiting sputum results in patients who are experiencing clinical symptoms. Regarding radiological investigations, the presence of pulmonary tuberculosis is obvious from a posterior-anterior chest X-ray with the occurrence of opacities most frequently in the upper zones. Cavitation and calcification may also be present. Regarding skin tests, tuberculin and its purified protein derivatives, PPD, are used in contact tracing and tuberculosis. Following intradermal injection, a positive response will be obtained in patients with tuberculosis infection, not necessarily acute, old infection or previous BCG vaccination. Negative responses may be obtained where there is overwhelming tuberculosis infection, administration of immunosuppressive agents, early infection or an insufficient amount of tuberculin was administered. Next we will briefly comment on the Mantoux test. This consists of the intradermal injection of varying quantities of tuberculin PPD, in the UK solutions of 10, 100 and 1000 units per milliliter are available, as well as the concentrated preparation 100,000 units per milliliter. The initial diagnostic dose is 1 unit, if subsequent tests are required 10 and then 100 units may be given. A positive response is indicated by an induration after 48 to 72 hours. If a negative response is obtained, the higher strength indicated above may then be used. The interpretation depends upon the history of the patient, such as previous BCG vaccination or tuberculosis infection. A response of 10 mm or more in the absence of these is suggestive of either previous or current infection. Household contacts aged 5 and over and close non-household contacts should be also tested. We will briefly talk about interferon gamma release assay, also called IGRA. This test is now recommended in patients who test positive to the Mantoux test or if the Mantoux test seems unreliable, e.g. patients previously exposed to TB or BCG vaccine. Interferon gamma release assay has been reported to be more accurate but much more expensive than the Mantoux test. Next we will discuss drug therapy of tuberculosis. Patients with tuberculosis can be managed outside the hospital unless infection is severe, compliance with therapy is a problem, other comorbidities are present or there are resistant organisms. The aim of the treatment is to cure the patient with an initial multiple drug regimen followed by a continuation treatment phase using 2 drugs to which the organism is sensitive. The use of at least 2 agents in combination limits the development of resistant organisms. It must be noted that the principal cause of treatment failure is the lack of patient cooperation. Negative cultures are usually obtained in about 3 months in 80 to 90% of patients, and for all patients in 5 to 6 months. Within 2 to 3 weeks of the start of the therapy, even smear-positive patients become non-infectious. It is important that during continuation therapy patients are reviewed at regular intervals to monitor progress or side effects and assess treatment compliance. Treatment is given for 6 to 12 months continuously. In poorly compliant patients, a thrice-weekly regimen, also called directly observed therapy, also called DOT, can be given. There is an option for a twice-weekly regimen, however this is not recommended in active disease. Pause the video and carefully scrutinize the table summarizing drug treatment of TB before advancing to the next slide. A 6-month regimen comprising rifampicin, isoniazid, pyrazinamide, and ethambutol for the initial 2 months followed by rifampicin and isoniazid for a further 4 months is recommended as standard treatment for adult respiratory tuberculosis, irrespective of the bacteriological status of the sputum, by both the British Thoracic Society and the National Institute for Clinical Excellence (NICE) Clinical Guideline 2011. This treatment regimen refers to the treatment of active TB, whereas latent TB may not require treatment. In addition, infection control is very important to prevent spread of TB on hospital wards. Refer to your local policy for this information. Generally, patients with active TB should be in a single room. TB patients should be advised to wear a mask outside of their isolation room for at least the first 2 weeks of the 4-drug treatment. In addition, immunocompromised patients, including HIV patients, should not be in the same room as TB patients. TB patients can be on the same ward as immunocompromised patients, however they must be in a negative pressure room. Next we will briefly discuss multi-drug resistant (MDR) TB. Multi-drug resistance can occur in patients who have been on previous TB multi-drug treatment or experienced previous TB treatment failure, are HIV positive, born in a country of high TB incidence or in contact with patients with MDR TB. MDR-TB is more common in men and between 25 and 44 years of age. In the case of MDR-TB, urgent molecular test for rifampicin resistance should be carried out. Ref. NICE Guidelines on Tuberculosis published January 2016. Next we will discuss the prevention of TB. Prevention is achieved through 1. Treatment of active cases. This will reduce the number of known patients with active tuberculosis. 2. Case finding, which entails detection and treatment of the unknown pool. This can be done through contacts, community surveying with miniature radiography, or direct smear examination of sputum. 3. BCG vaccination, Bacille Calmette-Guerin. This vaccine will provide 60 to 80% protection in young adults. 4. Chemoprophylaxis. The use of isoniazid at a dose of 300 mg daily is a practice that has been developed in some countries to deal with people at risk of developing active tuberculosis. In Britain this has not been widely adopted due to the fear of resistance, but the risk now appears slight and thus the practice is becoming more frequent. Next we will discuss bronchiectasis. This is a chronic pathological dilatation of the bronchi that involves chronic infection and inflammation. There is often a mixed bacterial infection with pneumococci and Haemophilus influenza. Other organisms such as Staphylococci, Klebsiella, Pseudomonas and anaerobes may be present. Most patients expectorate sputum regularly and some will be breathless with impaired lung function. Patients with bronchiectasis are at risk of disease progression, particularly where there is daily purulent sputum expectoration. Regarding its treatment, the initial antibiotic treatment is directed against the main organisms pneumococci, Haemophilus. Ampicillin, amoxicillin, cotrimoxazole, doxycycline or erythromycin are given for at least 5 to 7 days. Antibiotics are then directed against the bacteria isolated, if considered significant. The infecting agents change frequently, so the sputum should be bacteriologically examined on a regular basis. As antibiotics penetrate bronchiectatic pus poorly, systemic treatment can be supplemented by antibiotic inhalations such as neomycin 200 mg per milliliter, polymyxin B or gentamicin 10 mg per milliliter. Long-term treatment with doxycycline, azithromycin or cotrimoxazole is useful in some severe cases. Chest physiotherapy and postural drainage are very important in the prevention and treatment of infective exacerbations in bronchiectasis. Mucolytic agents appear to be of little value. Occasionally, surgical resection of lung tissue, that is lobectomy, is indicated when the bronchiectasis is localized, but this is seldom done nowadays. The British Thoracic Society state that possible indications for nebulizers are 1. Reversal of airways obstruction with bronchodilators in patients with and without asthma, 2. Improvement of mucus clearance, and 3. Reduction of the microbial load in the bronchial tree. In addition, they state that nebulized antibiotics should be used as an adjunct to regular home postural drainage and courses of oral or intravenous antibiotics for acute exacerbations. Nebulized colistin, aminoglycosides, anti-pseudomonal penicillins, and third-generation cephalosporins have been used. The objective of nebulized antimicrobial therapy is to reduce the colonizing microbial load in the lungs, improve symptoms, and prevent progression of the disease. Nebulized antimicrobial agents are usually prescribed for control of background symptoms and for the reduction of severity or prevention of acute exacerbations rather than for treatment of acute exacerbations. Next we will discuss methicillin-resistant Staphylococcus aureus (MRSA). Staphylococcus aureus frequently colonizes human skin and mucosa and can potentially colonize the lung. It is one of the most commonly talked about hospital-related infections. As MRSA is becoming increasingly common, most patients are swabbed nose, axilla, hairline, groin and mouth prior to coming into the hospital, especially before surgical procedures. If they are found to be MRSA positive, eradication treatment is started, which consists of the following treatment preparations. This may vary according to local guidelines. 1. Mepiricin 2% nasal ointment. Some MRSA are not sensitive to mepiricin, in which case Naseptin ointment should be used. Naseptin shouldn't be given in peanut allergic patients, thrice daily into both nostrils. 2. Chlorhexidine acetate 1% powder. After drying, apply chlorhexidine powder to axilla, groin, and all skin folds or creases. 3. Chlorhexidine gluconate 4% skin cleansing solution, e.g. Hibiscrub. It should be used in daily showering. On alternative days, the patient should be advised to wash their hair with it. 4. Chlorhexidine gluconate 0.2% mouthwash thrice daily and after eating, if MRSA is present in the throat. This treatment should be given for 5 days. All the above sites should be re-swabbed 48 hours after cessation of treatment. Respiratory MRSA infections carry a high mortality rate. Once MRSA infection is suspected, it should be treated adequately and promptly. Vancomycin and linezolid are generally the antibiotics of choice. Vancomycin is the first-line treatment in most patients who don't have history of vancomycin-resistant enterococci, also called VRE, infections. Vancomycin can cause red neck syndrome if it is infused faster than 10 mg per minute, therefore it is essential, as a clinical pharmacist, to endorse the drug chart appropriately, e.g. 1 g of vancomycin should be infused over 100 minutes, the minimum infusion time is 60 minutes. For 500 mg doses. In addition, concentrations of more than 5 mg per milliliter are not recommended unless the patient is fluid restricted, in which case 10 mg per milliliter can be tolerated. The dosing regimen is guided by the renal function as vancomycin is highly nephrotoxic, therefore taking pre-dose levels is essential. The first level should be taken before the third dose, within 60 minutes, of the dose, and it should lie between 10 to 15 mg/L. If the level is too high, the dosing interval should be extended. In patients with normal renal function, a 1 gram twice-daily dose is commonly used. Linezolid is a second choice, especially in VRE infections. It is given as 600 mg twice daily IV or orally depending on the circumstances. Baseline blood counts including platelets should be taken and patients monitored closely. The most common side effects include blood dyscrasias such as anemia, leukopenia, pancytopenia, and thrombocytopenia. Patients with impaired renal function and/or on therapy of long duration are at increased risk of developing thrombocytopenia. Therefore, platelets should be monitored at least twice a week and doctors alerted if platelets start to drop significantly. Linezolid should not be used in patients taking any medicinal product that inhibits monoamine oxidases, e.g. phenelzine, isocarboxazide, selagiline, meclobemide, or within 2 weeks of taking any such product. Telavancin was recently licensed for the treatment of HAP including nosocomial pneumonia and ventilator-associated pneumonia caused by MRSA. It is a lipoglycopeptide antibacterial agent. Telavancin was shown to be non-inferior to intravenous vancomycin in 2 independent studies. It is given at 10 mg per kilogram once daily for 7 to 21 days. It is nephrotoxic and it should be avoided in acute renal failure as it can increase incidence of death. Next we will discuss other resistant bacteria in respiratory tract infections. Regarding Streptococcus pneumoniae, as mentioned above, there is growing concern in relation to Streptococcus pneumoniae resistance. One of the reasons for this resistance is the overuse of penicillin and macrolide antibiotics, which can result in alteration in binding of a few penicillin-targeted proteins, causing reduced affinity for penicillin. There are over 90 pneumococcal types and only a small percentage is able to cause penicillin resistance. Therefore, it is still uncertain whether resistance to Streptococcus pneumoniae is definitely present and growing. Resistance to erythromycin has been reported as a result of genetic mutation in the target site or the ability of the bacteria to eliminate drug through drug efflux proteins. As tetracyclines are not commonly used in pneumonia, mainly as a third choice, there aren't many reports of resistance. Resistance to fluoroquinolones is more common, as they have been used widely due to moxifloxacin use in the treatment of non-severe CAP. Moxifloxacin was reported to be equivalent in efficacy to other commonly used antibiotics and the side effect profile of moxifloxacin is better than 1 gram thrice daily of amoxicillin and/or clarithromycin. Nevertheless, hepatic side effects associated with moxifloxacin render it only appropriate for use in CAP after other antibiotics have been tried. Regarding Haemophilus influenza, the percentage of penicillin resistance in Haemophilus influenza is still relatively small at around 15%, as reported by BSAC for the period between 1999 and 2006. As Haemophilus influenza is not a common pathogen in CAP or HAP, empirical treatment should not include beta-lactamase-resistant antibiotics. Legionella species have had resistance reported, but this is not common and they remain well targeted with rifampicin, macrolides and ciprofloxacin. Thank you.